Well, welcome everybody to the second learning session of this collaborative on the EMS Quality Improvement Airway Management Collaborative, and excited to see everybody here. Um, if you wouldn't mind, just in the chat, we want this to be as interactive as possible. If you would just type in the chat, what's the biggest challenge you have in doing this work around airway management, just to get us started, that'd be great. And since Michael's not quite here yet, I think I'll go ahead and go through his part of the introduction slide. So I'm channeling my inner Dr. Redliner here. And we're getting a couple of contributions here about your struggles, documentation, Sancio in particular, time and other projects, peri-intubation, vital sign documentation, availability for hands-on training, crew compliance, salty old medics. There you go. Time documentation, the peri-intubation stuff is a challenge. Collecting data, having enough data, other projects, documentation. It's always a challenge, and I know how trying to improve documentation sucks the life out of a culture and a workforce like few other things ever happen. So we have more than one salty old medic issue. That's good. Um, just wanted to acknowledge that these collaboratives don't happen without expert faculty. Part of the setup for breakthrough series collaboratives like this is that you really bring together a group of experts on both improvement science and the content, and we have a pretty extraordinary group of faculty members, including some of the world's leading airway management leaders, researchers, and physicians on that topic that are guiding our work here. Here's the kind of the updated project timeline, and the green star is as we are here at this moment. So this is the second learning session in the collaborative. Um, After this, we'll follow another action period, and one of the themes that you will hear throughout today is that we're going to really focus you on taking action and and testing ideas and testing change and really getting into the action phase as much as possible, and sharing your PDSA cycles and your actions as you go for them. That really is the the core work of this improvement. And then in September, we'll have our third learning session, which kind of brings the learning together to see what we've figured out. And then there'll be kind of a last cleanup period until we do our summative Congress and put together the final change package in January. That's actually 2026, not 2025. We're not going backwards on that one. Um, any questions or concerns about timeline stuff from anybody? If you're ready to dive in and take over, I would love it if you jump in, Mike.
Yeah, sure. Thank you so much. I apologize for being a few minutes after the time. I know Sheree and Mike are right on time, so I apologize for a few minutes delay here. An emergency on the emergency department side. So,
what are the odds?
What are the odds? What are the odds? So Mike was talking about the timeline. I think he did a great job. I was listening to him. He channeled me well. But again, I think that this is an exciting project. We've done a lot of work so far, and there's a reasonable amount to go as we are on our improvement journey. And so it's we're smack right here in the middle. But we've got some exciting stuff coming. So I think maybe if we can go to the next slide, Mike. And so again, I think what we're looking at really is these action period activities, thinking about kind of the various aspects of kind of collecting data, getting ready, kind of getting organized around this quality improvement project, and thinking about the specific interventions that we're going to be doing, looking at our driver diagrams and really starting to think about how we're going to implement projects to improve airway management more generally. We've had 7 teams who've connected with mentors from the Airway faculty and really started work on some of the proposed projects. I think if you go to the next slide, Mike, this is some of the data around what we've got going on. So 62 teams, 261 members, 4,000 over, almost 5,000 data points, and 72 changes tested. There's a lot of work that's going on among the agencies that are participating. And again, I think some of today is really thinking about that and thinking about looking at our data, looking at what the next steps are related to our improvement projects. I think the next slide is still mine as well. And so again, I think that we've done a lot of work around thinking about this driver diagram, about the specific areas that we can invest in to think, to identify our challenges in airway management and observation. I think, from my perspective, I think that we have a lot of opportunity. Every agency is going to be a little bit different. I think I can't see them on my immediate screen, but the Mount Sinai folks are here somewhere, I believe, and I just want to give them a shout out, Max Sierra and Drew Posner, Luis Castillo, who have been working on really, it's kind of an amazing, it's an amazing project in many ways, but most notably the evolution of the quality leaders thinking has led to kind of an evolution in the service around how we're thinking about airway. We've done some specific educational interventions and some awareness type of work. And I think that the idea of resuscitation before the mechanics of intubation is really helping people evolve their thinking about how we do airway management. And focusing on the vital signs and focusing on that work, I think it's blowing some people's minds. And I think it's blowing some people's minds in a good way, where it's slowly like bringing people into this space where it's not just about getting that tube, but it's really about rethinking the way that we resuscitate when somebody needs airway intervention. And so, I give a lot of credit to these guys who are really taking the agency through this, and we're looking forward to kind of watching our change as we think about not only that, but the different interventions that we'll do to make to help our agency and our paramedics and EMTs look at this evolution of airway management. So I think if you go to the next slide, Mike, this again is just a reminder of our aim, the overarching aim of the Airway Collaborative. One is to improve the use of waveform capnography to confirm and monitor all invasive airways. And then the second is to reduce the adverse events of peri-intubation hypoxia and hypotension. And again, I think there's going to be some tailored aims here, as you see below, for each agency, depending on where you're starting from and what are the specific goals that you're trying to reach as an organization. But again, I think this centers us in our work to remember exactly what we're trying to achieve, right? These are the things we know are important. These are the things that will help patients who are suffering from respiratory failure, respiratory distress. Anything I've missed, Shri or Mike, is I think that this is just an exciting moment in time where we're, again, checking in, looking at our data, thinking about where we are in the scope of this project, and then talking about what's next and how we're all going to move together to really improve for our patients.
I think this is great, Michael. I really appreciate it. Those of you that have kind of geeked out on improvement science know that usually in an aim, we like to include the how much improvement and by when. And we specifically didn't include those in this initial aim because we wanted to get baseline data for our group to be able to really understand where we are. And in order to be able to do that, we really need some complete data from folks. And this just shows this is a 0 to 100% y-axis scale here. We don't expect Airway 01 or Airway 05 to be at 100% because not all systems can contribute to that, but Airway 18 and Respiratory O2, we'd really like it to be close to that. And you can see that we're still missing data from a number of systems. So what I'd love is in the chat, if you've got specific issues being able to contribute your data, or anything we can help you with, ideally we'd like to get data from everybody who's a participant in this collaborative, um, to set it up, maybe some ticklers or reminders in your calendar to update your data on a regular basis. And with that, let's take a look at the data we've got, and I'd love to invite Dr. Jeff Jarvis to join me as a co-facilitator throughout the whole rest of our time together. You want to say hi, Jeff?
Hi, Jeff.
Hi, Jeff. I knew
You
that's what
had to know that was coming.
sounds good. So let's take a look at our first one. And Jeff, can you remind us what Adult Airway 01 is?
Absolutely. So sorry about any background noise there. I'm being attacked by a lawnmower even as we speak.
We're not
Uh,
hearing it.
Oh, good. So Airway 01 is, so in adults, we have the Airway 01 measure stratified, adults 18 or older, non-adults, pediatrics under 18. And this is the proportion of patients intubated for non-cardiac arrest who have successful endotracheal intubation on the first attempt, and there is no hypoxia or hypotension in the peri-intubation period. The peri-intubation period is defined as 3 minutes before the first attempt and 5 minutes after. And hypoxia is 90%, hypotension is 90%. And there are multiple challenges with this measure. You got to get the tube in the right place. You have to make sure the saturations are above the goals. But in order to do that, you also have to make sure you have vital signs documented. And I think we're finding that is a huge reason that people fail this measure is we're just not taking vital signs, or we're taking them and not getting them into an available source. So first pass intubation success without hypoxia or hypotension.
That, that is perfect. And I just want to draw your attention. One of the nice things that Jason and Cherie did for us here is to go through and add the denominator to each of the data points. And you can see there's only three contributors to this data point that looks like it is a big improvement. So unfortunately, we can't get excited about that one headed in that particular direction because we've got incomplete data from that particular perspective. But overall, this is a pretty steady state. How would you characterize our overall performance so far, Jeff?
Well, sorry, now I have a zoo barking. Um, Overall, I would say it's probably about what I expected. This is a really challenging measure. If you look at national performance, this is pretty much in line with national performance. I think when you combine the fact that if you define standard of care as standard practice, which you probably shouldn't, but if you do, I think you would say that the standard practice is that the only way to get the SATs up is to intubate. So the concept of pre-oxygenation is completely absent. And if you don't adequately pre-oxygenate, there's no way that this measure will do well. And then we know that the typical first pass success across all intubations in the field is around 77%. So I think this is probably expected. Our goal, obviously, is to get this measure up, but this really is a composite measure. So it may be that in order to move the needle on this, we have to move the needle on other measures first. And maybe we'll see more of that.
Sounds good. So this is the pediatric one, and And while it looks like the variation is much more dramatic here, one of the things to keep in mind is we don't do a lot of pediatric intubation. So the denominators is very small here. Any other thoughts on this one, Jeff?
Not really. I think it's the tyranny of small numbers. So in our system, we will be 100% on this, or zero, depending on the way you look at it, because we don't intubate children at all. So looking at numbers 11 in June of 23 was the highest we ever got. I'm just not sure we'll ever really see this get large enough. And from my understanding of the literature, I think that's probably a good thing.
Sounds good. Let's look at adult airway 18.
Yeah, so I think I would love to look at that last data point and say one data point, provided it shows improvement, is really good and significant. If it shows drop off, then obviously it's just one data point. That was sarcasm, by the way, just to
I
be
picked that
clear.
up.
So poor Mike's improvement brain doesn't explode. It looks like it's pretty standard, not standard, but controlled practice here. And we're above 90%. I think we probably should be higher than this. We're never going to be at 100 when you look at widespread data, but I think we probably can get closer to 95. That's my hope anyway. Um, so overall, though, I think 90 is a whole lot better than 45. There are a couple of challenges with this measure that I think people are identifying. One, it has to have a value, end-tidal CO2 value of greater than or equal to 5, basically because under 5, you can't see a discernible waveform. So it has to have a value, and it has to have, for confirmation method, the waveform capnography checked. And I think this is a concept of we just need to make sure that people understand how to measure this. The other alternative, obviously, is if you're abstracting your data on your own and you're looking at the waveform, then you're pretty confident it's waveform capnography, and you can count that as a success.
Sounds good. Definitely sounds good. So this is the pediatric version. Again, small numbers here at the bottom. Anything else on this one?
I don't think so.
All right, sounds good. So adult respiratory O2.
Yeah, and this is the challenge. So I think who knows what how many is that? One, two, three, four, five. Oh, so close. It's, I think, who knows? We'll see in another month or so if this trend continues and becomes above 6, but it is looking promising. I think the challenge with this measure is artifactual data. We're still looking at what the best way to capture this is. So the measure itself, just to be clear, is proportion of those patients who are hypoxic who get oxygen administered. I think one reason we may be seeing, if that turns out to be improvement, one reason we may be seeing that is there are multiple ways to capture oxygen administration, as many of the folks on this call have identified. If you're using a nebulizer, you can't use the nebulizer without oxygen, but it may not be captured. So hopefully increasing the capture on this will increase the performance. So what's your take on that, Mike, in terms of, is that real or not? Are we seeing a change?
And so looking, it's a little bit hard to see the full denominators here, but overall, um, the contribution to like the January and February is less than half of what it has been, or a third of what it has been earlier. So I'd want to see a little bit more data come in to know if this is true or not. But certainly we've got 1, 2, 3, 4, 5 points headed in the right direction from a trend perspective. So Jason, you're a little closer to this data. Any thoughts on it?
No, I think you're right. I think our ends are pretty small. It's not I don't think it's, I think people who are getting their data in are also working on the measure a little bit more. So I think you're probably
That makes sense.
seeing.
Yeah, so there may be a little bit of a selection bias.
Yeah,
I
and
would
so
say this is a selection bias on top of a selection bias, because if you're on this call, you have already selected yourself as someone who cares about airway management and want to improve it. So this is obviously just a representative sample of those of us who care.
that makes good sense. And I guess the other message here, I have a theory that maybe some folks who've not submitted data are embarrassed that they're not haven't been able to do changes or make improvements yet. And the encouragement is to please go ahead and continue to share your data, because that's the real world. Improvement work in the real world is much harder than the brochure indicates, and your contributions and baseline data, even if you're not able to take action or make improvements, is really important from the overall perspective.
Those damn brochures, somebody needs to work on those. They're never very accurate.
Right? And then so this is the pediatric version of that same one, right?
Right. Exactly. All the same caveats apply.
Same caveats. And so this is a metric that was added after we started the project. Jeff, you want to walk us through
Absolutely.
how?
Clearly, the world ended January 2025. So obviously, we have an N of one. So you either have to be 100 or 0% on this. So the measure that we're looking at here is adequate oxygen saturation before intubation. So did you adequately pre-oxygenate the patient before intubation? Again, we're excluding cardiac arrest and we're excluding supraglottics from this measure. And the reason for that, just to make sure everybody remembers, is we said with intubation, because it is a more complex procedure, has lower success rate, and typically takes longer, there's more opportunity for misadventure. And we can say, don't intubate until you pre-oxygenate. But sometimes there are situations where you can't do that and you still need to control the airway. Cardiac arrest comes to mind. You're never going to adequately, if you have 100% saturation in a cardiac arrest, I really don't know whether that's artifactual data or not. So you have to have an alternative, and that would be the supraglottic. So that's the reason we're not measuring it there. The pre-intubation period is 3 minutes, and that comes from the amount of time a person with normal tidal volume breathing an FiO2 of 1, takes to completely denitrogenate their lungs. It's an imprecise measure, but it's the best one we have until we can routinely measure in-tidal oxygen, which I don't see happening anytime soon.
Got it. And this is the pediatric version of that metric, which suffers from one team reporting it all, right? So not particularly meaningful data. One other thing I just wanted we wanted to highlight for folks is that in addition to the metrics that we have for the overall project, some teams have added custom measures in their own simple QI to be able to dial down and make things a little more nuanced. So the folks from Monroe Livingston EMS um, added respiratory O2, a primary impression of a respiratory complaint. So that's a subset of respiratory O2 that they're tracking in the Greater Piddleston Regional Ambulance. Also added one on the number of patients on oxygen. So those of you, as you're doing this, if you've got things that you want to drill down on or focus on within your system, you are invited to add as many extra measures to yours as you'd like, as long as you contribute to the overall ones for the project. And the folks in Albuquerque have gone through and they've really just kind of stratified the measures for their system. So anything else to add overall on measurement, getting data in and submitted to this group from Jeff or Jason, Cherie, anybody?
I don't have anything other than a question, and I'm curious from the folks on the call. Um, about whether how well people feel like they're able to measure Airway O1, and really whether if you're able to do this as a manual review of your monitor files, or if you're still using the just data exported from the chart.
So that's a question you're asking for people to answer in the chat?
Exactly. Yeah. I'm just really curious about how other folks are working on this.
So Atrium says they're manual only,
Seeing a lot of manuals. I think that's really where the data is best.
right?
But unfortunately, it takes people, and sometimes we don't have the luxury of having those people. But I'm glad to see we got quite a few here.
Yeah, it's a challenge here.
It is.
And
Yeah.
I guess the request is if you run into blockades and you go, I just can't quite get to this, please reach out and ask for help. We're happy to jump on Zooms. I'm happy to help put
Yeah.
smarter people than me on Zooms with you to help you sort this through. Um,
I
Marshall,
see somebody adopted Kirby is going to really enjoy that. I see somebody adopted Kirby chart. So love that.
okay, all right, there you go. Sounds good. Sounds good. So I think and actually the other one other question I've got just because it's a theory that we've got in the background. Um, do your crews know that you are part of this collaborative? Have you announced to your teams that you are actively part of this collaborative? Because we have a theory that if you inform people that they're part of it, yes, 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 updates often, great. This is what I was hoping for. If you haven't yet, please consider sharing it with folks. The Hawthorne effect is legal and improving airway. This is good.
Right.
And
Yeah. The challenge with the Hawthorne is how to maintain it.
right. Well, and sharing your data with folks,
Yeah.
temperature folks, this is great. Steve said that was the first change we made. Um, got it. Okay. Not yet, Gabe. All right. Sounds good. So, Tim, if you're ready, one of the things we'd like to move into is we've got a series of systems that have done some interesting work around this. So we want to give folks the opportunity to kind of highlight the work they've done, and this is where benchmarking comes into quality improvement, where you steal ideas from folks. So, Tim, you're welcome to share, and let's go for it here.
So we're talking about some of the stories that were coming in from the groups around the country and some of the difficulties that they were having. And one thing that came into my mind is that for us, and this is a lot like a 12-step program, I can't tell you the right answer. I can only tell you how I did it. So I can tell you what worked for us. And what worked for us was we had to be very deliberate about anything that we wanted to improve. We had to define very well, and then we had to share it with people. So I just wanted to talk a little bit about defining the process. You hear a lot of different terms going around about, so I just wanted to be very clear about what I'm talking about. So when I talk about, so to me, it occurs sort of in a continuum. We can talk about process measures which are a lot like, did you follow the steps? If I lay out a set of steps for you, did you follow the steps? Somewhere in the middle is the process outcome, right? So if we're talking about intubation, was the patient intubated successfully? Did they have any episodes of hypoxia, right? Those are all outcomes of the process. And then all the way over on the right, we can talk a little bit about patient outcome measures, right? Did the patient survive? What was their neurologic status at the end? So I'm going to talk about how we define all those three things in our process, right? So you don't, we get a lot of pushback, right? So, and I'm sure that anybody who does a lot of quality work, we get a lot of pushback from our folks about why do we have to do it this way, and why are you guys so strict about the way you want us to do that? And there's definitely a place for strictly defining a process, right? Is there evidence that indicates that doing something a certain way improves the patient outcomes? Is it a high risk, low frequency process? Is it technical or complex? Or are you trying to manifest some sort of culture change, right? We've always done it this way, and we're gonna, there's a lot of muscle memory and a lot of organizational memory built into that. And really, there is an art to this, right? Balancing process versus management versus micromanagement. And I'll talk a little about how we deal with acute coronary syndrome, just because it's the simplest process, or one of the simplest processes that we look at, right? So we only judge successful process delivery for acute coronary syndrome based on three things. Did they do an EKG within 10 minutes? Did they give the patient an aspirin? And did they transmit the EKG? We don't worry about, did they give oxygen? Did they start an IV? Did they give nitrates? Did they give fentanyl? Arbitrary scene time limits, all that stuff. Those things may have a place. I'm not saying they're completely unimportant, but where is there evidence to support that it makes a difference in the patient outcome? EKG within 10 minutes, that we equate that to early identification of the STEMI. Aspirin administration, there's evidence that says that it reduces morbidity and mortality. And transmission of the EKG, early notification of the cath lab. Those three things, and if our folks do those three things, that's what we're worried about, and we tend not to hassle them on all the other stuff. And that's how we walk that fine line between our folks saying, you're micromanaging me and you're nitpicking, and getting the patient what they need and what we know that will contribute to their positive outcome. So defining your process, right? We're talking about intubation, right? Is there evidence? So for us, when we rolled out a new video laryngoscope, and we had this problem where we had very poor first pass success. So we put together a group of people. We looked at what evidence was available about the intubation process itself. We got together a group of experts, the medical director. We had been piloting these devices in the field for a little over a year. So we had a couple of folks who were experts at using them. Like I said, we got the medical director in there. We looked at the manufacturer's recommendations, and we came up with a process. And we said, since this is a relatively high risk, low frequency, it's not like putting on an EKG. We're not doing it every day, especially in our system where we've got 250 paramedics and we're only intubating 900 people a year. So it's high risk, low frequency, and it can have a huge impact on the outcome of the patient. So we looked at all those things, and we came up with a very detailed and specific set of, this is the way we do business. And we're okay with that. We're happy saying, all right, this is our playbook. This is how we're going to do this skill. And we want you to do it this way every time. So once the powers that be had that process, or that process defined, and that the way of doing things, we had to communicate to our folks. There's a bunch of different ways you can do that, right? Policy, a guideline. We chose to use a checklist. For our continuing education, we have the checklist there. We actually put a checklist sticker on every laryngoscope blade. So it's right there in their face. They can't do the intubation without seeing the checklist. We make them practice with it, both in the station when they do, a quarterly skills or something like that. We'll have them we want them to use the checklist every time, and to follow the prescribed way of doing it that we've set forth. And then we have quality management, right? So we've put out there, we defined our process, we communicated it to them, and then we have to make sure that they're actually doing it, right? We use first pass. Are they following the process? What are they doing well? What are they not doing well? And I'm not saying that you have to go and knock heads on everybody who doesn't advance the bougie before they do the tube on every intubation, but at least know in the aggregate what your folks are doing well, what they're missing, and where they can improve. And then what to do when you find deficiencies. If you find that there are, you have widespread failure to comply with your process, or failure to use your process, maybe that's when you roll the checklist out. Maybe that's when you go out and meet with people and retrain them, or you give them the old, yeah, we were really serious about this. So, you do that through your PDSA cycles that you've already been doing, and you monitor for change and improvement. Is the process having the desired outcomes, right? So if you do put together a good process that's valid, you're going to see the process outcome measures, the things like are you able to intubate patients without hypoxia and hypotension? You should see those either improving or maintaining a good performance on. How do you know when the process is the problem? So like I said, we put together a panel of experts. We looked at a bunch of different things, but who knows at the end of the day that what we came up with is the right way to do it, right? I'm sure that your folks who are out there in the field doing it every day are going to let you know if they see something that can be done better. But what I would say is that once you define your process, don't be anxious to change it or say that it's a failure, say that the process is the problem and we have to do it a different way in order to get better patient outcomes or process outcomes without getting 100% compliance. The point is that you can't say that the process is a failure until you have your folks doing the process reliably, which was something that we were pressured a lot to do, right? When we couldn't get our process outcome, our first pass intubation up to where we wanted it to be, a lot of people were telling us, well, it's the process, it's the process, it's the process. And we need to change this. We need to change step 2 of the process to this, or we don't need suction as much. And we were very hesitant to do that because you can't tell me that the process is bad if you're not doing the process. And then the Holy Grail, right? So after you get past and this collaborative doesn't really talk about long-term patient outcome measures, but we should be thinking forward to, okay, if we are able to get our first pass intubation success without hypoxia or hypotension to 95%, what sort of things should we be measuring to make sure that that has a positive outcome on the patient, right? Should we look at 30-day mortality or days in ICU for this cohort of patients that undergoes intubation? But focusing on those patient outcomes, patient outcome measures are probably a little bit beyond the scope of what we're doing here. And then the takeaways, right? Define how you do business, distribute your playbook. You can't hold your folks accountable or be surprised if they don't do what you want them to do unless you adequately communicate with them, right? Make sure they're following the playbook. Use the PDSA cycles to improve your process measures, and then improving your process measures should improve the patient outcome measures, is what I meant to say there.
Thank you so much, Tim. Any questions, comments from anybody about this? Jeff, any thoughts?
Yeah, I do. I love it. I was struck by your checklist. Not so much what you have on the checklist. I mean, that looks great, but the fact that you glued it to the laryngoscope blade, therefore assuring everybody would use it. I'm curious whether everybody uses it. We did something similar. We glued it to, we got a little yellow box that our laryngoscope handle is in. And what I find, I just thought that would guarantee, of course, if you have to go physically through the checklist to get to the blade, you'll have to use it. And we still see tons of people that don't use the checklist, leading to some of our most common failures. I'm curious what your experience with that has been.
I would say that we're getting better at it. We're still certainly not 100% with checklist use. I know that that's one of the things that we hammer the supervisors on, right? If you could walk into a room and you see them doing the intubation, ask them where the checklist is. As a culture, as an organization, checklists are fairly new to us, and there's always been, I want to say this was probably our first one that we rolled out, and there was a lot of pushback on it, a lot of resentment, and a lot of just, well, I don't need to do that. I do this every day, right? A lot of pride and ego that goes into not using that. But we've been trying to normalize them, right? We've got a ROSC checklist that we, I think for us, half the battle was getting it in front of them when they needed it, right? Because the original thought was, oh, well, we'll just have this book that has all the checklists in it, right? And that, unless it's like right in front of them when they need it, they're not going to use it. So I would say that we're getting better at it, and I'm hope with more normalization of using checklists in not just this one process, that will get better going forward.
And so we've got another question. Thank you for that, Tim. We got another question from James. He says, I have a checklist question. Do you have your crews upload your completed checklist to their patient care reports?
No, we do. We have one checklist that is for downgrading, so a tiered system. When the paramedic downgrades from ALS down to BLS, they have a checklist that they go through in a timeout, sort of with the ALS and BLS crew. That resides in the patient care report and then becomes memorialized in the patient care report. But this is just a paper sticker that's right on the laryngoscope blade. So we just asked them to use it. And I think, especially in the downgrade checklist is more of a do confirm. This is a redo checklist. I think for a redo checklist that that is being used in a high pressure situation, I don't know that they're, I'm not expecting them to actually physically check it with a, I'm just expecting them to go down it in there, look at it, go down the steps from start to finish and use it. So I don't, what I would expect if we made them take a picture of it would be that they just went at the end of the call and checked all the boxes and then uploaded it.
If you did it with a picture, they take a picture once and then just upload it every time.
Right, right. Yeah, it'd be, we'd find it at the desktop.
I know how medics work. James, did that answer your question?
Yes, it did. Thank you very much. We're in the process of building out a drug-assisted airway program, and through medical direction, we're building a checklist and looking at the idea of having it integrated into our patient care report so that as we're going through it, they can check off directly on the screen as we're going to make sure that everybody's on the same page and we're doing it appropriately.
It also comes down to our culture, just real quick. We tend to not, or our folks, especially with a critical patient, not touch the patient care report until after the call, right? We want them hands-on, focused on the patient, not with their head down in the computer. So we really teach our folks, don't even mess with that thing until after the patient's turned over. So that's another reason, another thing you got to think about. How do your folks normally operate, especially in a high stress situation like that?
Sounds good. And we've got a question from let's see, we got a couple of them here. Marshall, do you want to unmute and ask your question?
Yeah, my question is more general about checklists, but has anyone looked at how checklists actually impede care?
Say more about your theory there, Marshall.
Well, I think about it, if we're thinking about it from like a crew resource management perspective, where, pilots are trying to navigate a plane that's falling out of the sky, they run through their checklists. But what I was thinking about is that there's things that they can anticipate, and it's like predictive. My plane is falling out of the sky. There are only so many things that can be going wrong. And so, they'll go through and work through their priorities. But a crashing patient isn't always, you can't always anticipate a crashing patient, or you can't always predict what your patient is going to do. And so as you're working through your checklist, and the minute that your patient deviates, well, now that your checklist kind of becomes irrelevant or an impediment to the care that you're delivering. That is, unless you have designed your checklist in such a way that allows flexibility and deviation. Does that make sense?
It definitely does to me, and we've got some folks in the circle here who have a lot of experience with checklists. I'd love to. I just saw Maya pop on. I know this is one of her areas of passion. Any thoughts from any of you who've done this work? Because I think it's a really good question, Marshall.
I think that there's sort of two responses to that. Is one, that you're making sure that the checklist is designed for the right thing. So in this context, the checklist is designed specifically for the scope of an individual procedure that somebody has deemed to be indicated, right? So the checklist is not covering, is the procedure indicated, or which may change as the dynamics of your patients actually change. And we'll talk a little bit in our program is we spend a lot of time selecting for people who are actually deciding to do the procedure and can resuscitate an individual appropriately, but we need some safety around the procedure itself because of the high cognitive load. So I think it's like, what is the scope of your checklist, and everybody really knowing what the scope of the checklist is. But I also think that a checklist, the idea of a checklist is a broad idea, but the checklist you actually use is a change idea that you need to test. And so, like, saying I'm going to design a checklist de novo and it's going to help patients is not actually how a checklist should be designed. The checklist needs to actually be designed and tested in such a way to say, does this particular checklist actually improve care? Because until you've actually tested that, it is only a theory that that individual checklist will improve care in the realistic context.
So that was just lecture 2 and the basics of improvement science. Thank you, Maya. That's perfect. Anybody else have any thoughts around this before we move on to our next presentation? We do have one question, Tim, from Jennifer. Would you be willing to share? This is a different subject. Your ALS to BLS worksheet.
Yeah. I was just looking to see if I'm pretty sure it's uploaded in the image trend library, but I'll put a link in the chat.
Great. Thank you so much. Thank you so much. And Cherie asked folks to email copies of your checklist to her so we can have a little library, and that would be an interesting kind of meta-analysis to look at all of them and see what we think around this. I think if we're good to go, it's time to move on. Alex, are you ready to go from just down the road here in Austin?
I am. Can you guys hear me?
Yes.
All right. Let me see if I can get the share the right screen. Share. All right. I think that's it.
Oh, it looks perfect.
All right. Well, hello, everybody. Good morning and or afternoon, wherever you might be located. My name is Alex Moore. I'm a captain at Austin Travis County EMS. I work in the yet to be clearly defined clinical quality and patient safety realm here. We've kind of had some restructuring recently, but I've done quality work for a little while and worked in the system for a few years, and we are super excited to be part of this collaborative. Talked with Jason Gilliam about it years ago and have spent all kinds of time drumming people up. So I'm going to share some of our early interventions and talk about what we have going so far. So I think this is pretty much where everybody's at. It's put in a massive amount of time and energy on just trying to understand our baseline. This is, probably the most resource intensive part of the entire project in my mind, but definitely an essential one. I unfortunately do not have any meaningful results and key data to share with anybody, but I do have some of our early interventions to talk about and hopefully get some feedback from you guys as well. So one thing that was immediately obvious whenever we did get our data back is, boy, this is a big project. Improvement is hard to begin with, but unfortunately we made it a lot harder when we selected this topic of, around, especially, Airway 01 and Airway 05. These are relatively uncommon occurrences, so we don't get as many opportunities to test change. And these are extremely complex and challenging cases. There's a lot of variables. It is very easy to get overwhelmed in this. And, where do we start? Where do we begin? So the most helpful thing for me when we think about these problems and where we're going to start attacking them is to remember that, because these are continuous processes, this is continuous quality improvement. We ultimately have all the time in the world. We don't need to feel rushed to come up with all the magic solutions right now. And so we can afford to spend that additional time really understanding the problem beyond just the raw data. So before we get into some of the PDSA cycles and things that we've been starting off with, I wanted to share a little bit about Austin Travis County EMS as a system. So we are a municipal third service system. We have 40 to 50 units, depending on time of day, that are operating at any given time. Got our annual call volume for last year approximated there. We do not routinely intubate in cardiac arrest situations. So we're often using primarily supraglottic airways. And we also only RSI with some specialized credential paramedics. So this is a higher level of credential for paramedics that's kind of optional, voluntarily sought out by the individual provider. We don't have a standardized deployment strategy for those. So it means that our RSIs are not necessarily a routine part of our patient care. It's just sort of those specialized providers, as they are available, do have that ability to perform that procedure. As that's the bulk of the Airway 01 and Airway 05 cases, obviously that limits the opportunity that we have to actually go through that procedure. So long before we even really started in this collaborative, one of the areas of focus for us has been on just finding ways to improve skill proficiency, give all the providers in our system the opportunity to rehearse their innovation skills and keep those sharp. So, I would imagine this is probably not a unique problem. I'm guessing that just about everybody here has had similar challenges in in the EMS industry. So, when we looked at our original data, our baseline data going back a couple years, one of the major issues, and this was not a surprise to us, was just the skill proficiency, the first pass success, which is obviously a core component of some of these measures. So, once you've identified the problem, where do you start? So we know we have a problem, or at least something we want to improve. We know that the old tried and true method doesn't work, which is basically measure the problem, tell your medics that they're bad at it, and ask them politely to stop, or maybe not so politely, right? Which I think probably everybody here knows doesn't really do anything other than make you the bad guy and, have everybody stop listening to you. So, we decided we're going to go for a modern and more enlightened approach, which is measure the problem, tell everybody that we are collectively bad at it. But the important difference here is ask for their help, right? So the first real intervention that we did, and where we're still really putting most of our energy, is sharing as much of our information as we can, as much of our findings as we can with our individual providers and ask them to study it and reflect on it and give us recommendations for where we can start this process of actually improving. You know, we have, and you know, pretty much everybody in this industry has a team of dedicated skilled providers. They really care about their patient's outcome. You know, everybody has probably heard the adage that nobody shows up to work in this kind of industry intending to do a bad job. We all want to do the best possible thing for our patient. So obviously the first step is just to let providers know how we're measuring success, what that means to us, what best possible care looks like, and ask for their help in ideas to try to achieve that on a more consistent basis. So, you know, our providers know that hypoxia is bad. They know that in tidal CO2 confirmation is the gold standard. But now that we've done a lot of this training and education, we've had a lot of these discussions. Now they have a more tangible concept of how we're measuring that success, and they have a reference point for system performance. They have a motivation to really start driving that improvement. That way, it's not just a handful of people in an office trying to come up with the magic solution and, you know, then cramming it down everybody's throats. So in other words, you know, our emphasis has been on educating and empowering our frontline providers to be able to drive change. A couple ways that we've tried to do that, other than just the education, is to invite frontline providers and stakeholders from different aspects of the agency to a monthly work group where we kind of talk through some of the challenges that we're seeing and solicit suggestions. Unfortunately, you know, all of that stuff takes a lot of time. We don't have a lot of actionable data on some of those solutions that have been recommended yet, but we'll share a couple of them in just a minute. We're also doing hands-on CE for our quarterly CE, where Airway is going to be a huge focus, and it also gives us a lot of opportunity to kind of grab people and ask them for their feedback and recommendations. So we're looking forward to that. So one of the things that we realized early is that airway management in general in our system had kind of taken on there was this impression that this was primarily an ALS problem, that it was a problem for paramedics to solve, which, you know, as I'm sure you guys understand, could not be further from the truth. So we're really targeting our BLS providers in our system with airway management education. We're doing a lot of hands-on practice with BLS airway management skills, as well as giving them some education on the ALS aspects of airway, you know, advanced airway management, such as an RSI, so that they know what that looks like. They are essential team members in executing that procedure. They're not going to perform the intubation themselves, but they're probably the most important piece of the puzzle as far as getting, you know, an adequate SAP before we start the procedure, and setting up equipment, monitoring the patient's vitals during the procedure. So giving them awareness of how that procedure works and empowering them to really drive these aspects of patient safety and quality that we're looking to improve throughout that case. We're hoping that that's going to make a huge impact in our overall measures. So I did want to touch a little bit on the skill issue that we've been struggling with here, and some of the interventions that we've considered to try to improve that. Because, I mean, ultimately you can't have first pass success, and you can't do it without hypoxia and hypotension if nobody's really comfortable doing the procedure in the first place. So that's been a gap for this system for a while. So, you know, we had to find ways to improve that. Luckily, our hand got kind of forced, like some of you maybe that were using King Vision up until recently, it's now been discontinued. So that VL device is no longer available, and we had to make a switch to new hardware. Luckily, that means we get to jump on that as an excuse to do hands-on training for the entire field in a new device, which is that hands-on training time is something that had really been lacking in recent years, and so we're just starting to roll this out and getting every provider ample opportunity to practice with the new hardware, and we're hoping that makes a significant impact. So our next concept that came out of this Airway work group is trying to work towards a deliberate practice model. So what this means is engaging providers with regular skill practice opportunities, charging them with ownership of their own skills and abilities in that area in innovation, and then giving them regular check-ins with a skilled coach to kind of point out little technique issues and things like that, and give them incremental recommendations for how they can improve that practice. So we have a model built out for that, and that's going to roll out after our initial hardware UE scope rollout. So we're pretty excited about what that's going to look like. So some other things that we haven't really fleshed out yet, but it's obviously on everybody's radar, is what checklist we already have an Airway checklist. I'm going to pull that up in a little bit, but we're actually looking at making some changes to it to make it a little bit more user friendly. And some other ideas that we've thrown around that have been discussed here previously is the equipment setup. What bag do we use, and what equipment's included? Not having to run all over the ambulance for everything that you need for the procedure should significantly improve our chances of success, right? And then some additional training that we've considered. So this is our RSI checklist that this has been used in our system since I think we implemented. I mean, actually, Jason Gilliam's probably going to know this better than me, but implemented RSI in the system several years ago, and this has been around more or less since it was rolled out. But actually, in discussing this checklist and how it's formatted with our work group, kind of in line with one of the questions from the previous presentation, is this too complicated and too RSI centric to really facilitate the key pieces of a safe and effective intubation? That's kind of what we're mulling right now. We don't have an updated version to share with you, but that is kind of where our focus is as far as the checklist stuff. But this draft is I believe in the resources page on Simple QI. So if you're interested, or if you have any recommendations for how to trim it down a little bit, please reach out to us. But as always, this is we've got plenty more to do. I just want to reiterate to everybody that may be a little bit daunted by this is if you start with soliciting feedback, especially on such a complex procedure, complex situation from frontline providers, and just use that to drive your test of change, that is where you're going to get the most leverage, in my experience. So with that, I will take any questions anybody has.
Thank you, Alex. Any questions for Alex? And while you're thinking of any questions for Alex, there's a question. This is a Jeff Jarvis question in the chat from Marina about a measure clarification. Jeff, do you want to jump on that real quick?
You bet. Yeah, I was just reading that to make sure I understand. The question is how many vital signs do you need to confirm that it's continuous? And this is one where we had to go with a pragmatic answer, and the answer is you need one, sometime between 3 minutes and 0. So the way the measure is written is that there's at least one value, 94 or above, and no values lower than. So it's a great question. I would love to require continuous, but you know, ultimately there's no such thing as continuous. It's just like calculus, smaller and smaller intervals. So we had to pick something. And we opted for the something that we can measure rather than that's good enough rather than something we can't measure that's perfect. Yeah, it's a great question. Thank you.
Sounds like you nailed the answer for her. And Tim, thank you for sharing your downgrade checklist. And Cherie,
Oh, and I'm
one
sorry,
thing.
Mike. I just saw the second part of the question.
Okay.
It is would um, any 3 minutes count of oxygen saturations greater than 94? And the answer is no. So you can think about a situation where you have someone, I don't know, whose airway, they're losing the ability to protect their airway. It's not an oxygenation problem. They were oxygenating just fine right up until their airway closed. So you could have perfect SATs when you get on scene. Let's say that you give them medications and they lose their airway. Now their SATs drop. The whole point of the pre-oxygenation is to build up a buffer zone in the lungs by removing the nitrogen and giving yourself enough time to adequately do the procedure. So it has to be the 3 minutes immediately preceding the attempt.
Perfect. Thank you. Let's see. Edward asked question for any or all of these measures. Did anyone utilize LifePak 15 change any default settings on the monitor to help capture better or more consistent data, performance, timing parameters, etc.? It sounds like it's a wide open question for everybody. Is anybody doing this?
I will take, we don't use life packs, but all of the monitors have this ability to change things. I suspect you tweak it in slightly different ways. One of our biggest problems is getting medics, despite the fact that it's clearly on the checklist, getting medics to actually switch the monitor to Q2 vital signs. And if you don't record the vital signs, it doesn't get imported, and frequently you don't get a blood pressure. So I have my knee-jerk response is, well, this is great. Here's a system forcing function. We'll just change the default on the monitors to every 2 minutes. And then I remembered I'm a paramedic too, and that's rapidly approaching punitive because there are so many patients that don't need Q2-minute vital signs. So ultimately, what I'll tell you is I would love the answer to this. I don't know what the best thing is. Maybe you can convince me that it's not punitive, and maybe I should be doing that, but I just haven't figured out what to do here.
Sounds
I see
good.
Drew has his question up or
Yeah.
his hand
Well,
up.
Let's get
I was just going to say,
Go ahead, Drew.
yeah, I was just going to say that for the life packs, one thing we've done is we've defaulted them to be vitals Q5 minutes and end title displays on the primary screen all the time. And then if crews don't need those settings, they can adjust them manually for each patient, but we'd rather have the default set for the more serious patients than for the less serious patients, and rely on crews to add that to another thing to do when they've already got this high cognitive load situation.
Sounds good. Sounds good. Well, let's go ahead. Marshall, are you ready? Are you up for doing your section? This is my friend Marshall from DC Fire and EMS.
Hi, everybody. Good morning, good afternoon, depending on where you are. So I'm Marshall Washik. I'm the Continuous Quality Improvement Manager for DC Fire and EMS. I'm going to talk about some of the work that we've been doing over the last couple months. And my project, or PDSA, presentation is on the use of plant experimentation to understand advanced airway management. So just a quick overview. I'm going to talk a little bit about DC, how busy we are, the equipment we use, the baseline data, kind of the impetus for being involved in this project. And then I'm going to talk about planned experimentation and going to summarize what we learned throughout this entire process. So for those of you that aren't familiar, DC has a residential population of about 720,000 people. During the workday, that swells to 1.5 million, so it gets pretty dense. For perspective, that's about 28,000 people per square mile. When you take out all the parks and waters and stuff, there's 52 square miles that people live and work and move around in. So to cover all that space and all those people, we have a workforce of about 2,400, 350 paramedics. We do about 220,000 calls a year, with total EMS responses being around 185,000. So we're a pretty busy department, but that's not uniformly distributed. In terms of advanced airway equipment, we currently use the glide scope. We also use the iGel for our supraglottic airway, and we will be moving to the glide scope 2. We are kind of in this transition period as well, moving to some new equipment. So I'll talk a little bit more about that in a moment. So here's some of our baseline data. I looked at this last fall and just looked at our first pass success rates over our June, July, August, September, October, 6-month period. And our first pass success rates hovering around 72%, second pass around 85%, and our third pass attempt is less than 40. I went back and I looked at our protocols, and we don't actually have limits on how many times we can intubate a patient or how many attempts that we can have, which I found really interesting and something to address. But in terms of supraglottic airways, anytime that there was a failure on the first pass and they went to an iGel, they were successful 100% of the time, and the same thing with the second pass. We do a fair number of intubations a week. The median number is around 12 tubes a week, or in a 7-day period. Most of that is for cardiac arrest, but it's still a pretty significant number in my opinion. So that's our baseline data. We obviously have some room for improvement. All right, so here's just a quick overview of our project charter. Advanced airway management, high risk, fairly high frequency interventions that have room for improvement. Some of the issues that we found is that 72% first pass success rate is pretty low. We also have some evidence that when our paramedics are intubating, we're actually traumatizing the airway. And that may or may not be something up for discussion about whether that's something that we should consider when doing improvement. But I think particularly in patients that aren't in cardiac arrests, who you decide to take their airway, you have to be extra judicious when you're putting in a laryngoscope down into their pharynx, larynx, their airway. And then we also don't really actually know how many patients are becoming hypoxic or hypotensive during advanced airway placement by our paramedics. So we hope by this July to ensure that 100% of our invasive airway procedures use capnography for placement, confirmation, and monitoring, and to reduce the incidence of peri-intubation hypoxia and hypotension by 50%. So that's where we're at. So our expected benefits and outcomes, standardize equipment, process, increase awareness of monitoring equipment, and trying to reduce the adverse events associated with it. So planned experimentation. Planned experimentation is a structured approach to testing changes in a system or process by deliberately introducing variations under controlled conditions to evaluate the impact. It helps identify cause and effect relationships, optimize performance, and support data-driven decision-making. So why is this important? We've been talking a lot about process and system and advanced airway management, but what I have found is that built in all of us are assumptions about airway management process. And we assume that all of our paramedics know how to do this. All of our paramedics know how to do it the same way. All of our paramedics understand and interpret the protocols the same way. They use the same equipment. They follow the same steps. Same thing with our BLS providers, that they know. We assume that they have at least some baseline level of knowledge in which to support somebody who is engaging in, trying to take somebody's airway or advanced airway management. And so planned experimentation starts to take all of those different ideas and factors and jumbles them up and tries to understand, all right, given this process and all these tools and equipment and decisions and stuff, what actually works, and where are particular areas where factors may interact with each other, and how they can either work synergistically to improve your process, or in which they impede each other and cause problems. And so essentially, I'm using planned experimentation as a way to challenge our assumptions. So to do that, I developed a PDSA around simulation. And so again, like I said, we're using the glide scope. We are in the process of moving to a new system. And so we got a couple other VL systems to test out and play with in a simulated setting. And so I thought this would be an optimal opportunity to run a planned experimentation. Experiment. So I wanted to look at what combinations of factors help to optimize our process. And I looked at specifically looking at the 3 different VL systems, our current system versus 2 other systems. And I wanted to target a total time of less than 40 seconds between breaths. So I don't have the factors up here, but the factors, I'll go over them in the next slide. But I wanted to look at how a 2-person ETI contributes to efficiency. If there was a difference between systems. I also wanted to look at how stylet choice might actually affect intubation time. And we're using the Zoll system for our monitor, and we have the real BVM technology, and so we're able to get some ventilation feedback while we're pre-oxygenating and post-oxygenating. So planned experimentation comes in a number of different. There's a number of different tools that fall under the umbrella of planned experimentation. The most common one, well, I shouldn't say the most common one, one that is really talked about a lot is something called a 2K factorial analysis. which is similar to this, which is an orthogonal array test. Both kind of do the same thing, but essentially what it does is it takes a combination of factors, jumbles them up, randomizes them, and creates a series of tests that you go through sequentially. The purpose of that is to be able to draw some cause and effect relationships. Since you're randomizing your combination of factors, you can start to deduce, is there a causal relationship here? And so here's one of the tables that I put together. There were five factors that I was looking at. I looked at the video laryngoscope system. So I tested the GlideScope Go, the OneScope, and the UE scope. I also looked at feedback versus no feedback. So, the provider was ventilating, looking at the monitor, pre-oxygenating, Fred the head, and then intubating, versus just ventilating and not looking at it. Looked at bougie versus rigid / malleable stylet. And then the other thing that I was interested in looking at was BVM device. I know folks have mentioned or talked about the use of a child BVM for an adult to prevent hyperventilation. So I wanted to throw that in there just to see, is there an effect? And then I looked at provider configuration, whereas there was just one person working on the airway versus 2 paramedics working on the airway. And then the last column over here is the total intubation time between breaths. And as you can see, there's a lot of variation, at least in this individual provider. So getting a little bit more into the data. So I ran 5 providers through this simulation. They all each had their own orthogonal array test table. So all the data has been randomized, and it's all even been randomized across providers. And so what you can see here, the blue line represents the median intubation time. And there's quite a bit of variation by provider, which I thought was interesting and also kind of not surprising. What I did find surprising here, but I shouldn't have, is that these last 2 providers, they're fairly new paramedics. They work in some of the busiest parts of our city, and they're really hyper engaged in EMS and just work in general. And you can see the consistency of their performance compared to these 3 other providers who they're paramedics, but they're officers. And these 2 paramedics are officers, and this paramedic is in a different role, not really a street provider role, but still technically a paramedic and should still be able to perform as a paramedic. And you can see the amount of variation in that person's performance. So when I looked at performance by individual scope, minus this data point here, the OneScope actually performed really well. So, again, there's variation across all of them, all of the scopes. But yeah, I think, in my opinion, if I were the one to make a decision, once the OneScope performance probably would be the best here for us. But on the whole, it's actually kind of provider dependent. and that's not included in the slide here, but yeah, anyways. So the other thing that we can look at is just the effects of all of the different factors on intubation time. So theoretically, you can see that the UE scope contributed to had the most variation within our testing. Within our testing, and the glide scope and the one scope on average are pretty similar, but the glide scope Go had more variability. And I should probably pause there for a second and explain these two graphs. So one of the things that we look at in planned experimentation is for effect. And so it takes, if you think about it, like kind of from like a regression standpoint, all things being equal, these factors on average produce this kind of result. And so, yeah, so everything being equal, the glide scope Go and the one scope Go are pretty similar. And the same thing for the number of providers helping to facilitate endotracheal intubation. Though the two-person has slightly more variability in it compared to one person just focusing in on the airway. As for the adult bag versus the child bag, the adult bag actually had better performance compared to the child bag on average, and the child had more variation within it. So looking at this and interpreting this, it warrants further study, but I wouldn't recommend using a child bag for ventilating an adult patient to prevent hyperventilation. It seems like not a great idea. And then interestingly enough, I looked at the effects of bougie type, stylet type, and the bougie actually had higher kind of like intubation time. And I believe Dr. Jarvis did some research on this some time ago, and they also found that bougie was associated with increased intubation time.
Not
okay. No?
That one wasn't me.
Are you sure?
Well, no, I don't think so.
Pretty sure I cited one of your papers.
Well, maybe. I did.
Okay.
Now you're gaslighting me, man.
Sorry.
I appreciate the credit, even if it wasn't me.
Okay. And so, so these two graphs right here really start to get at, in my view, understanding the complexity of the process of endotracheal intubation. And so this graph, these are interaction graphs. So it looks at two factors combined and their effect on total intubation time in seconds. And so the graph over here, the stylet and the number of providers on total intubation time. And what we see is that, again, the rigid / malleable stylet improved better. But when you have two people engaged in intubation, with a bougie, it's significantly higher. And then when you have two people with just a provider working with a rigid malleable stylet, that actually improves performance over an individual with just a rigid malleable stylet. And then interestingly enough here, looking at feedback and stylet choice, when the provider was intubating, looking at the feedback and paying attention, and using a rigid / malleable stylet, it actually improved over no feedback with a rigid and malleable stylet. So what does this mean? It means that there's something going on between the relationship between stylet choice and the number of people. And we can theorize and hypothesize around why that is. And to me, what this suggests, and it's again open for discussion, is that the person who is intubating needs to spend their cognitive space, capacity, focusing in on what they have to do. And so when you incorporate a bougie into it, there's the step of coordinating the insertion and then sliding the tube over, and then kind of in a coordinated fashion, keeping the bougie within the trachea, and then sliding the tube over, pulling it out, and inflating it, and then confirming its location. And then the same thing with ventilation feedback is that as you're ventilating, what I think is when you're ventilating and you're focusing in on something, squeezing and, for a certain amount of time and like a cadence, you almost get in kind of like a rhythm. And then you can just grab the tube and insert it and then pull it out. And it seems to flow smoothly. So those are my thoughts and theories on this. So in summary, advanced airway management is complex and it's a time-constrained process. Improving it requires a thorough understanding of all the contributing factors. Provider level variation might be the biggest factor to account for in your system. And keep in mind how many factors may either interact, again, impede or synergize with other factors in the process. And so my key takeaway from all of this is reducing harms associated with advanced airway management requires us to have a comprehensive understanding of the process while appreciating its complexity and taking into consideration external factors that may impact performance as well. And that's that.
Thank you, Marshall. I appreciate your willingness to jump into the deep end of the most complex approaches to quality improvement. Planned experimentation is not for the faint of heart, but it really does allow you to test multiple factors at the same time to figure out which ones give you the biggest bang for your buck. And I appreciate you sharing that.
All right. Is my screen coming across okay?
It's coming across perfect.
All right. So, my name's Joe Spangler. I'm with Sedgwick County EMS. I'm one of the training officers. I got a counterpart with me, Chris Boyven. He and I are working closely on this collaborative. And we are in Kansas, and yes, it is a state. So a quick overview though, we got a population of about 500,000, and last year we ran about 71,000 calls. We have a mixed staffing. We're primarily designed to be a dual paramedic, but just, you know, due to the staffing everybody else is having, we got trucks staffed with EMTs and AEMTs and at least one paramedic. We have 3 field supervisors at peak, and then 21 ambulances at peak, with 13 of them staffed on a 24-hour basis and 8 of them staffed 12 hours at a time. We have a total of 157 paramedics on staff, and 21 of them have the ability to initiate the RSI procedure. But any number of the paramedics that we have can participate within the RSI procedure. We use Kaleidoscope Go as our current system, but it's kind of reaching the end of life, and we're probably going to be at least looking at other options. We kind of felt like we're an outlier in the group that we still use the Sansio or Health mobile EMS or the EPCR system. And we do use First Pass with a human review on all the flag tickets. And we went back and had First Pass build us tests for the NEMSQA measures, and had them backdated from 2023. And so we went back and hand reviewed all those. But in my tenure here, I have never known our organization to participate in a project this big. So we knew that we were going to have to get some buy-in from the administration to participate and use this particular project as a way to perform meaningful QA and hopefully lead to a robust QI process. We've been using, like I said, First Pass for a number of years for the QA process, but there's sometimes it just didn't feel like we were doing anything more than collecting data. So once we got in and started looking at some of our data, this is for Airway 01. You know, we were kind of like, oof. But it was also stuff that we were never looking at previous to joining the collaborative. So that we knew that we had some room for improvement, and so how do we do that? And so, you know, we went through and thought, how were we going to collect this data? So we thought, well, we already got First Pass, so let's leverage that and continue to hand review the tickets that are flagged. So we had, you know, first watch rebuild or build tests specific to the NEMSQA measures. We also had some tests built with the whole new NEMSIS update for export. So we just leveraged all of that. And we thought, well, we can obviously use this data that we collect to provide Chris and I as training officers to support the education. And we quickly identified, and I think even from the chat this morning, you know, that documentation was a big factor in meeting these measures. And we also identified that there was some knowledge deficit, and that we do have a airway management protocol, and some of the parameters within our protocol actually supersede what NEMSQA has. Like our SpO2 to treat is below 94%. So we couldn't figure out why are we doing so poorly when we should be doing something at 93% versus waiting till it gets down to 90. There was also some, you know, just changes in the documentation expectations that we knew that we were going to have to get everybody on board with. So some of the stuff that we started doing, Chris and I, we kind of call it the hit print campaign, so that I can only speak to LifePack. The 15 is that we know that it'll capture the waveform in the background, but it doesn't always capture the end tidal value when we first apply it to a patient, unless you physically interact with the monitor. So if we told them at bare minimum, after that intubation is done and you get your waveform and a value pops up on the screen, hit print to document not just the waveform, but the value as well. So when you import that data into the ticket, it'll put it in there for you. And we use Ninth Brain as well as kind of a repository of documents. And we're currently rebuilding a run log, or building a run log for ET video submission for review, and building a rubric on reviewing those ET tube innovations. The other thing was that, and I think it's come up several other times in some previous measure meetings, was we kind of got out of the habit of documenting oxygen because we always made that presumption that if we're giving a breathing treatment, we were using oxygen. So we kind of got out of the practice of that, but through this collaborative, we learned that we needed to be sure that we're starting to document that, because also it's part of the NEMSIS reportings as well. So this was one of our first PDSAs that we went through and completed. And it's related to using first pass and kind of automating, the NEMSQL measures. And we ran it for about a month, and we've learned that in Airway 01, there was just so many moving parts. First pass was having difficulty just differentiating between cardiac arrest and non-arrest calls. And some of that's just because of the way calls were getting documented and imported from dispatch information and such. So we just decided that in this case, hand reviewing all tickets that meet Airway 01 criteria would be best done on just a fully manual review. And so that's the direction we took, and we've left all the other ones automated. So we provided the service. Once we got the ball rolling on this, we did a service-wide town hall meeting to do kind of the initial education on the measures and the changes in the documentation expectation. Chris and I put a podcast together, and we provided some of the initial data to providers on the findings that we did, or that we had. And then we brought attention to our current airway management protocol to address that organizational drift. We also provided additional education on changes to documentation, treatment guidelines, and new expectations related to NEMSQL measures, like in a service-wide announcement. So kind of do the three-pronged attack, if you will. So that now that we've been, involved in this collaborative for a while now, we continue to communicate with providers on what our current service compliance is on the NEMSQL measures. We do participate in a quarterly QA meeting with our medical director, sharing the compliance data. We reemphasize the documentation expectations. And then we incorporated the NEMSQL measures and service compliance in the training courses, continue to do podcast discussions. We also have a provider compliance like dashboard that each individual provider has access to, that's not just the NEMSQL measures, but to all of our first pass measures. And just as we've recently gone through or released a new set of protocols that included some new medications, and opened up within the protocols, it opened up the use of push pressors. One of the new medications we also got was norepinephrine. So it gave us an opportunity to really drive home the fact of resuscitating the patient before we intubate somebody. So, fluid resuscitation goals along with pressor use if it's called for. And then also just reiterated that just because you can doesn't mean you should. So since then, we started looking at the data and we've had a steady increase in our compliance on the Airway 01. We have not engineered any changes like on the NIBP cycles, only because, we know that using an NIBP has its own faults and limitations. And so, we've given the opportunity or the flexibility for the providers to, if they want to do a manual pressure, there it is. You don't have to use an NIBP, just with the expectation that, we, within the peri-intubation phase, that we do collect that set of vitals. Overall, from looking at everybody else's measures where data was complete, we don't have a huge sample, but we felt like we're probably in the majority. So we just did our February one this morning. And we had 6 successes out of 9. So 9 was our denominator there. So 7, 3s, 4s has been the numbers on our denominators in the past 6 months or so.
And I'm just before you move on here real quick, Joe, I just want to point out to everybody that from the perspective of improvement science, you've got 8 data points above the center line here, which is a meaningful shift from the statistical perspective and improvement. And since this is a run chart, you actually only need 6, but you've got 8. So this is exactly the kinds of charts we're hoping to produce for everybody in this collaborative. So that's well done. I just wanted to call that out before you continued, Joe.
Yeah, and I mean, Chris and I were, really glad to see that happen. When we first looked at it, we were kind of like, this can't be right. What did we do wrong with the data input? And we went back through and looked and, we're not fudging our numbers. It's for real. And so we're just really happy that at least in this, we're moving in the right direction. But really that's all I got for all we did. And it wasn't anything spectacular or anything.
But it's producing real results, which matters. What questions does anybody have for Joe around any of this?
Less a question than and more of a congratulations. Strong work.
Absolutely.
Thank you.
Absolutely.
I can't do it alone. I mean, all our providers got on board, and they were really excited to hear that we were involved in a project like this. So I think that really helped. And I think just that open communication with all of the providers and sharing the data, good, bad, and different.
Yeah, there's nothing that fuels an improvement machine better than sharing charts like this with the folks that produce those results. That's great. I think we'll go ahead and move on. Tom, are you ready to jump in here and share your stuff?
Cool. Can you guys see that okay?
There you go. That looks perfect.
All right. Well, I'm Tom Growie, so I'm the medical director for the City of Kenosha Fire Department. And I'm here with Nick Bankowski, who I'll let him kind of introduce himself real quick, and we're going to kind of tag team this.
So I'm Nick Bankowski. I'm a line clinician, line paramedic in City Kenosha Fire Department. Been here 5 years. I had my bachelor's in poli-sci. A little outside the box there, but really excited to show this off.
Cool. Right. Well, thanks for having us. So a little bit about the city of Kenosha. So the city of Kenosha is a small urban city. It's just very southeast in Wisconsin, on Lake Michigan. It's got a population of about 98,000. We run about 12,000 calls a year, about roughly 10 codes a month, and manage about 11 to 12 airways a month, kind of depending. Maybe we get like one damn airway a month-ish. More in the summer. I think when we were doing more traumas, that kind of get flown out because we don't have a trauma center by us. Yeah, and then we run 5, sometimes 6 ALS ambulances, and we're very privileged, I would say, where we have 3 people we put on our ambulances, so 2 paramedics and an EMT on every ambulance, and then they staff 3 on the ambulances, excuse me, on the fire apparatus as well. The thing I want to point out about Kenosha is for our system, we have 1 EMS division chief, and that's the EMS person. So we don't have an army. We don't have like a nice like group of quality improvement people. We don't have a team of educators. It's really our EMS division chief, and then me, and I'm I think like about 0.15% of my FTE is with Kenosha. So really what we're going to talk about is kind of how we do quality improvement with a smaller, kind of office. So we do some of these big projects with really empowering a lot of providers to kind of push us forward, and specifically around airway management.
So, in the traditional sense of how ours work as a small group, it was more the leadership dictated how we would look at things, what we would look at in particular, and everything stemmed from the chief and the med control, and it was more reactionary. A crew did something, they could have improved, but it was more disciplinary, and it was real top-down approach from how we had handled patient care. So if we go to the next slide, how we look at it now is that our line clinicians are 2 paramedics and the EMT on the ambulance now have a much bigger say in how we approach subjects such as training or how we approach our innovation stuff and airway. When we started doing this stuff, we were already looking at some of the data on how to improve our airways, and it's good to implement what we were doing into the standard that NEMSCO wanted. Let's see where I'm at. How it breaks down for our CQI team is we have a representative from each station and an alternative in case there's a vacation or a sick leave time. And then, so each of those stations, then we have what we call a 2% position. This was a negotiated position with the fire union that 3 people would get 2% of their salary over the year to do this additional work. And that was our lead CQI coordinator, the education coordinator, and the equipment supply person. They all get an additional amount of money to do all this extra work. At our meetings on the first Friday of the month, we also have representatives from City Dispatch, the Kenosha Police Department, and then Med Control, Dr. Graway in this case, and then our chief. And to highlight, we only have 1 white shirt or chief in this situation. Everyone else in the team is line paramedics. Currently, we have like 1 officer because she was just promoted, but outside of that, it's all line personnel. So how it comes down is CQI coordinator will talk at these meetings, and he'll bring up specific types of calls we want to review over the month, be it airway, trauma, flight for life initiated or air medical initiated calls, or pediatrics, that we just review a handful to see what trends we can see and if there's anything we need to improve on. Then station reps like myself will go back to the stations and we'll talk to each crew saying, hey, this is what we're looking at this month. This is what we've noticed. Do you guys have any ideas or do you have any thoughts about this project? A big one that came out recently, the doctor will talk about with our suctioning equipment.
Yeah, and the other thing I'll point out with this is like the way that we do a lot of projects and really everything is the coordinator is kind of running the show with our station reps are kind of the people who are really implementing a lot of our PDSAs, and they're kind of going back to their firehouse and testing these cycles out, and then bringing information back kind of at the next month for how things went. So, and even in this setting, like, so Nick is one of the station reps who's kind of running, overseeing all of our like airway quality improvement stuff with NEMSCLA. So it is very like bottom up, is the way that we tend to do this. So airway improvement is kind of what we're focused on a little bit. So we're going to highlight some of our big kind of the drivers we've spent a lot of effort on, and how we've implemented this, and then just kind of really emphasize our bottom up approach to this. So when we first started looking at airway improvement a few years ago, and we had occasional smattering of CMAC videos to look at. We weren't like regularly recording these and didn't have a process for that. It was pretty clear that a lot of our missed airways were because people were not suctioning. So we, thinking about this from a quality improvement approach, I put this fishbone diagram up at a CQI meeting and said, hey, this is kind of what I've noticed from watching these videos. Like, what's kind of going on? What do you guys think are the barriers here? And really what we came up with really fell into a couple different places. So number one, people didn't really realize that suctioning was as big of a problem, because they're not watching all these videos. They're like intubating one patient, and then maybe in a month, maybe even fewer, depending on where they're working, and maybe involved in one or two airways in a period of time. So they're not really realizing this. They didn't bring the suction in. And when I asked people why, they're like, well, it doesn't work. And I was pretty surprised by how many suction devices we went and turned on and literally didn't even work, which was clearly a barrier. And then we were at this point where we were doing airway training kind of every year, every couple of years. And we weren't doing any like contaminated airway training. So of course, people aren't seeing the value in suction when it doesn't work and when we're not training on it and things like that. So the way that our QI team kind of focused on improving this is we had a group of people, it happened to be led by our coordinator at the time, who investigated a bunch of new suction equipment. Long story short, none of it's any better than anything else. We just needed new batteries in the devices that we had, and once we put new batteries in, they were probably like 30 years old. Those work great. We had some money, got salad mannequins, and Jim DeCanto is like a good friend of ours. He lives 30 minutes from us, which we're really lucky. So he came down and did some training with us, and we've kind of increased our cycles. So we're doing airway training in person twice a year at a minimum. And then this whole clinician factors is kind of the other thing. So we have built more of a practice around everybody taking the suction in with them now that it works and they see the value in it. And the biggest roadblock that we're dealing with right now is we're not having as many missed airways from suctioning, but when we do see it and we talk to crews about it, their point is, I didn't know I needed the suction. Like I bagged the patient, he was bagging okay. There wasn't a bunch of vomit on scene. I thought it was going to be all right. And then when they put the laryngoscope in, they're like surprised by what they find, So again, very well-intentioned clinicians who are doing assessments, the takeaway is the assessment is just not helpful, So our biggest message that we just did in our most recent training is 100% of intubations need suction. Doesn't matter what your assessment is. I know you guys do good assessments, but there's no good way to know what's down there until you get in there with a laryngoscope. So that's what we just talked about at training last month, that even if you don't think you need suction, you need suction before every intubation. So we'll keep monitoring as we're watching more CMAC videos now and kind of seeing how that improves.
Cool. All right. So when we talked about the CMAC videos, originally we would only have the person intubating would try to capture it if they remembered, and that would be the end of it. It wouldn't go anywhere. It'd go to a drive on our group, and we wouldn't see it again. Moving forward, we developed this feedback sheets to look at anytime we did a dam airway or a RSI, rapid sequence intubation, and we compare that to the cardiac arrest intubations, and we were able to factor them out by the use of a paralytic. So anytime a paralytic was used to intubate, I would get a I would get an email, the doctor would get an email, and the chief would get an email, and we'd review the video. We'd review how they did on it. So if it took one pass, a second pass, if they ended up going to an eye gel, and we were able to use this video and now attach it to a forum to send back to the station rep, where they would debrief on the process of the airway they were looking at. While we're doing that, we've noticed we're trying to refine it so it's just that segment that we want to talk about, and the crew can see same day what happened on that intubation so they can learn from it.
And it's the responsibility of our CQI reps at each station to pull the videos off the CMAC every time they go to shift and then get it uploaded to the sheet.
Like you said, we do semi-annual training normally in February and September, where every paramedic on the department goes through salad training as a refresher. Because, like you said, sometimes you can go a month or two without intubating, especially when we want to look at those contaminated airways. We started investing in high fidelity models that would better simulate a live patient. We also have the options to request that from the supply coordinator, where we can do weekly trainings on intubations if we haven't done it in a while. So our first pass, we talked about implementing the Dash 1 that we've talked from NEMSCA and how we can start pre-oxygenating and maintaining the blood pressure before we even attempt to intubate. So now that we have norepi on board the ambulance, we can bring up the blood pressure and have better outcomes. We were noticing in these cardiac or non-cardiac arrest intubations, so anytime we give a paralytic, we were able to pull the report and see, oh, this patient was hypoxic or hypotensive, leading to them to go into cardiac arrest and such as.
Yeah, and I think, and the other thing we've been trying to do with the Dash 1A to get more buy-in is call it what it is. It's a Dash 1A airway. So I think like naming it is really important. I think it's easy to go and say, try not to have hypotension. I mean, not try not, but don't have hypotension, don't have hypoxia, avoid these things. But I think when you give something a name, like it sticks a little bit. And what I've seen from these meetings and from a couple other people I know that do HEM stuff, they like brag about their Dash 1A airways. So it's really about like, how do you reframe the convo from, I got first pass success to, hey doc, I got Dash 1A. So that's something we've been trying to kind of build a new culture around to kind of get people to think about this a little differently.
So one of the other airway measures we were looking at is the waveform capnography. So we were noticing crews weren't putting the end tidal on, and we decided we would just take that thought process out and just put the end tidal onto the BVM prior to them even getting a BVM. So in every ambulance, every BVM is preloaded with our end tidal CO2 so that an EMT on scene can just plug it into the Zoll and we're good to go. And then we talked about this during the Dash 1A, is that we're now looking at the documentation and implementation of getting someone pre-oxygenated before we even attempt to intubate. Some of the things we're looking at the future, we recently participated in the Wyman group, and we started looking at possibly in our next cycle to look at ventilator use. Right now, we're kind of have our hands full implementing blood products onto the ambulances. So we're trying to keep it step by step, not to overload anyone. But this is far future endeavors we're looking at now.
And I think from an education standpoint, it's about how do we move from, okay, you can check out the salad mannequin, which everybody says they want to do, but when push comes to shove, like people have other responsibilities, so nobody actually does it. To hey, we're gonna drop this off at your firehouse. We're gonna set it up on a table. We're gonna leave it here for a week. Go through and get reps in. Because as much as we want to, try to train on this as much as we can when we're together, we can still only get together twice a year, So at some point, like keeping these skills up, how can we just make it easier and easier for people to do this stuff in the firehouse without the need for all the hoopla that goes into these big refresher sessions that we put on.
That's it for our presentation.
That's
Anything else?
wonderful. And one of the I sent this to you in the chat, Tom. Your discovery on the suction dynamic and your fix and address for it would make a great EMS1 article. I predict that many, if not most, EMS systems have a very similar dynamic but aren't aware of it. And you're sharing that, if you'd be up for it, has the potential to help a whole bunch of patients that you'll never see or know about. I think that was really good stuff.
Yeah, that'd be great. And we spent that was something we spent a lot of time on. And yeah, it's interesting how much you don't you discover through these like cycles when you talk to people and go through, it's like, who would have thought that we had all these suctions that just didn't work on ambulances, right? For more than 2 seconds, right? So
Absolutely. And of course, I flash back to all the crappy suction units I've used over the course of my career and similar issues. Thank you for that. Any other questions or thoughts? Jeff, anything on that one?
Yeah, the battery issue, or the dead suction, it is amazing to me. We have a real gap in battery life on suction units. They're horrible. We have to leave the damn things plugged in all the time. I had this great solution to the problem of our medics not taking suction in. And I'm like, okay, we'll just attach the suction to the stretcher. I'm like, that's great, Jeff, but they have to be plugged in all the time. Like, what the?
Right.
This is a great area. Our vendor partners can help us by getting some batteries that work or that last.
Yeah.
Great.
So in other words, I very much feel your pain. I think most of us do.
Love it. Well, let's move to our last of our partner presentations today. Shane, are you here and ready?
Shane is on a call because he's on the road today. So
Maya, we get Maya.
I'm covering. And there's a few folks from our team, which is multiple agencies on here, who are gonna feel free to interrupt me and add as needed. Just to give a little, I'm Maya Dorset from Rochester, New York, but we have a little bit of a unique system for our Airway Collaborative. We are not a single EMS agency. We actually entered the Airway Collaborative as an EMS region within New York. So New York has 17 EMS regions. And we cover Monroe Livingston, which is Monroe County, which has an urban center, including Rochester, the city of Rochester, an entire county-based EMS agency called Livingston County. And we've undertaken Airway 01 and Airway 18 as 2 separate quality improvement projects. And for the purposes of here, I'm specifically talking about Airway 01. But in our region, RSI, or Drug Assisted Airway Management, is a separate level credential that happens at the regional level. And so we enables us to do cross-agency response, where we have providers who have gone through a regional process for credentialing, which I'll talk a little bit about. But they essentially, if you think about the EMS agencies aren't exactly along these town lines, but within this region, there's 12 separate ALS agencies that operate, but a single RSI provider from a given area can actually do cross-agency response, depending, they go to through central dispatch, and people make that request. And our previous process had eligibility criteria, an initial knowledge-based exam, some case-based discussion, and then finally like a high fidelity simulation exam with one of the EMS physicians as their partner. But the entire focus of our credentialing program was on the decision of sort of risk benefit of doing this procedure in the field. So like on indications for the procedure, and really focused on this escalating approach to airway management. And we thought, until we looked at our data, that we were actually doing okay. We definitely had some issues. And one of the things that we need to know is I'm going to call this, Jeff Jarvis, I'm sorry, RSI, because I do not live in Texas. I live in New York State, and we have state protocols, and it is called the RSI protocol in New York State. And the way that it is written is it's a regional option. So we have a regional option where we allow RSI within our region, but we do it under this policy where we have a regional level credential, and that's different than different states within New York. And I think this is important because we operate with certain constraints of what it is to have state level protocols. So when we looked at our overall performance on Airway 01, and the way we did this is because we have this regional level credential, we have an Airway registry for every response for one of these RSI requests. The way that we track responses is there's a red cap survey that for the last 7 years, people have had to fill out. So I can track every single RSI request and review those. But when we looked at our performance, our data actually mirrored kind of the national data, which is the most common issue was actually documentation, was the absence of vital signs being done. But I also felt pretty strongly that the absence of the evidence of absence is not the absence of evidence, which is sometimes people don't get vital signs because the patients are sicker and the stat's harder to get because the patient's poorly perfused or the blood pressure is cycling. But we took a lot of what we learned from what was done at MedStar and said, how do we instill a process in this and study what the failures are to make it so that we don't focus on the documentation problem. We focus on developing a clinical process that fixes that. And so we built this driver diagram. Our aim was to improve first pass success without peri-intubation hypotension or hypoxia. I forgot the hypoxia in there, to 75%. But when we analyzed our failures, one was on first pass success. We were like 80, I don't know what we were, like in the mid 80s on first pass success. But right, we have a smaller group of providers obtaining and documenting peri-intubation vital signs and then optimizing the peri-intubation conditions, and came up with a bunch of secondary drivers. And the first thing that we did was we had an open meeting for all EMS clinicians in our area. We actually had 2 of them. And in the first one, we presented our data and we solicited change ideas from all the clinicians in our area. And so people like voluntarily logged in. And then in the second one, what we did is we took all of these different lists and we engaged them in telling us what do they think the potential impact of those interventions are, what were the feasibility and the effort. And the goal of this was, one, I think we got better feedback on what those change ideas would be. We did this also for Airway 18, but I'm not talking about that here. But it also got commitment from a bunch of the EMS leadership and frontline clinicians who then joined our team of improvement to help develop solutions. So the main ideas were that we did not actually have a process or a checklist that worked across our region. Mandatory video laryngoscopy, right? I have 12 ALS agencies. We have different video laryngoscopes, and there's agencies that did not actually have video laryngoscopes when we started. Deliberate practice training. We'll talk about mandatory monitor file submission. Communicating what those expectations are, because lots of people didn't know what the expectations were, and then the use of recordable VL. And then we sort of mapped these out and looking at status versus impact, which was, one, we knew that we'd get the biggest bang for our buck if we could instill, and the goal is not to even just have like impact now, but looking for sustained impact. If we could create process where no process existed. And so we looked at to see where did we have like very low process, and then where did people think that we would have a big impact. And that sort of came about of saying, like, if we could have process standardization, mandatory video laryngoscopy was going to be a longer practice thing and deliberate practice training, but we're still working on this. But there were some things that could have significant impact, we thought, but that were not actually like that hard to do. And that was about communicating expectations and feedback. So the very first thing that we did after we had these initial meetings is this was the communication, and we have a defined set of RSI providers. So for all agency leadership, as well as to everybody who works as an RSI clinician. We basically sent out, and they actually read our communications because it's a smaller group. This is not the same as sending an email to the entire system. This is like a defined group of people who are like really invested in having this credential. Of what the expectations were, what our regional performance, what our aim was, and like what the expectations were for around documentation. But we used the same communication as we decided that we were going to develop a checklist, but that like Maya Dorset was not going to develop the checklist. The people who do the work were going to develop the checklists. And so there was optional simulation sessions that they signed up to participate in that were going to be rapid cycle PDSA testing of different checklists in the context of simulations. And so what happened there, and the one other thing is that for expectations, we built a dashboard. So I maintain a dashboard of everybody's performance that doesn't have their name. It just goes by their cert number. But they actually, every single RSI provider in our region could see what their individual performance was on the metric, which some people found very surprising and actually galvanized people in some of the improvement project. And then we developed the standardized, basically copying very similar to what MedStar did, is develop standardized feedback forms. So I make one of these for every single RSI performed within our region, which we have about 3 to 5 per month. So it's actually not such a big burden. The bigger burden was me getting access to the monitor files for every single agency in our region, which has now been solved. So the checklist, I don't think Shane is back from the call. And if Kevin wants to interrupt me here on some of this process, or Heather, or either one of them, please do so. The initial checklist was the one that was on the left. And one thing that I think is really important here is that there were no doctors involved in the development of this checklist. That was really, really important, because while I would like to say that, people will tell me that my ideas are stupid and I should like shove it and this is what we're going to do, the reality is that they're not going to do that if I am there necessarily. And so it was really important that this was completely centered and developed by the people who are doing the work. And so there was actually one initial checklist that I developed that got trashed immediately, which was wonderful. And then this was an initial checklist that was developed, and Kevin, or I don't know if you want to talk a little bit about the process of how this was implemented. I'm sort of putting you on the spot. You can say no, but
that's okay. You mean like, so after this first initial draft on the left came out, we, like Dr. Rousseau was talking about, there were sim sessions where people signed up, and the first group got to run through it a couple of times with some different scenarios and offer their feedback. Then we redid it again, and then the next series of folks ran through it and offered their feedback. But it was, each time we had a chance to actively go through the entire list and demonstrate to other providers in the room how we use a checklist. So it wasn't just like, can you check this box? It was, let's actually do the things. And because how I use a checklist is different than how Heather may use a checklist, or how Dr. Dorset may use a checklist, right? And trying to standardize it across all folks so that everybody can have their nuances in it. It took several cycles, and that's why you see like the different things along the way. And one of the things that even came up was one person was colorblind. So how do we shade it so that colorblind people can see this checklist, right? They're like, everybody was involved at some step.
And one of the things, right, like they did this testing, they realized that if they had the equipment list, and if it wasn't all on separate lines, things would get forgotten off the equipment list, and they learned that. And scenarios included both situations, which was pretty straightforward, versus situations where a patient had refractory hypoxia or hypotension, and would the checklist actually catch that circumstance and lead to a different pathway for safer patient care. One of the things that we had been developing in the background is for specialty care transport, we had this recorded grasshopper line where somebody would call an on-call EMS physician specifically for specialty care transport. We developed, that got updated so that it had recording, but we developed a separate line that's called the EMS physician line, because what we wanted was, we didn't think that there was a discussion amongst the EMS docs where we have a consortium model. And we didn't all think that every single patient needed DSI. And that is also complicated in the context of New York State protocols. And we thought, like, not every single patient we take for needs this procedure, but we want to stop that if a patient has hypoxia, that you have some level of expertise on the phone that can help you navigate patient hypoxia and potentially do DSI or something, which is allowed if you have a physician order to do it in the context of New York State protocols. And so we actually developed this line. And one of the things that was tested is, even before we had the line, we didn't have a physician there, but we had a physician on call to answer the phone calls. So that was testing the process of, can you actually make this phone call? And are you getting helpful advice from one of the EMS physicians? It has to be. We didn't want standard med control to answer these, was one of the things that was tested. And the end up was this particular checklist that was at the end of all these PDSA cycles with all RSI clinicians who voluntarily showed up to participate in this process, was the checklist that was developed. So what ended up happening is, the next thing is, so if you think about like the initial development of a change and then moving to a broader group and implementation, we needed to get every single RSI provider to know the exact same expectations and to be trained in the use of this checklist. And one of the things that was really great is that we had this group that helped develop the checklist, who became really like the clinical leadership for the education, because they were part of the development. They knew how it worked. So this was sort of like the next communication that went out. We were reminded of sort of the dashboard performance. And what we did is share the checklist and talked about all the different changes that were made. And then we developed a process that was either a doc with one of our, clinical leaders, or two paramedics who were in our, our Airway collaborative group. We ran hands-on simulation sessions for every single RSI provider in the region over the course of 2 weeks. And each one of these involved a minimum of 2 cases, one that was pretty straightforward, and showed them how do you integrate a checklist into your clinical practice, and then also a case where a patient was hypoxic, which would give them practice in doing the EMS physician line. And the other thing on the EMS doc side, we realized that we don't always give the same advice, and that we didn't have a lot of didn't have as much standardization as we'd like. And it allowed us to actually give each other feedback on the med control side, and discuss how should some of these cases be best managed. And there was educational videos that they had to do that sort of demonstrate this process. The other thing that was really helpful here is, so we had our initial group of people who were engaged in doing this checklist. Right now, this is a broader group, and we got feedback about, in what form do you want the checklist in your clinical practice? Because some people like stuff on badge cards. Some people do not like badge cards. They want things in the intubation kit. So in the end, and we also found you have to put, when I did this, you have to put the end title on a separate line, even though most of our agencies at this point actually preload end title on their BVMs. So this is, and includes the number, but it made it so that every single RSI provider now has the EMS physician line physically in their phone. So this is the pre-hospital RSI checklist that we have. And then as part of this is that we want it so it's like in every intubation kit. This is sort of a half sheet that's laminated. The idea was also that we should combine this with the cardiac arrest checklist so that all our ALS providers are familiar with this, and they're just on 2 different sides. We put some med dosing here because we were encouraged to use hand heavy. We use hand heavy in our region, but we realized that when you're using your phone to both for hand heavy and call the EMS physician line, it was like a lot. And because for a multitude of reasons, the post-intubation sedation doses were also, they're hard to find in our hand heavy. And the cardiac arrest intubation checklist was developed by watching a lot of videos, including things, as you will see, that the airway plan timeout is lead with suction, because I also just watch videos of very wet airways over and over and over again. So these have now been sent to every agency in our region to print, fold in half, and laminate, because they actually fit into the intubation kits. And then the hard thing is this is a long thing and it's like microscopic if you try and put this on a badge card. So we developed and got feedback on, I don't know if you guys can see me, like a two-sided badge card, which just arrived today. And will be distributed for those who want a badge card, because some people are badge card people and some people are kit people, but it makes it so that we can put this in different ways that people can use. So this is our data. We collected our initial data, freaked out, and paused RSI onboarding in our region until we could develop a safer process. And this is sort of where we've, gone through, and we've done our simulation training, and we'll see where we are next month. But we do have, we've got 5 points above the median. But overall, I think getting feedback. So we've had our first field RSI where the checklist was used, and this is the feedback, which was really fantastic because it actually worked in the context of patient care. And I don't think that would have worked, or people would have been as engaged if they weren't engaged in the development of the tool to help them do the work. So as far as our next steps, our plan is to actually revise our credentialing program and how we do it, and integrate a bunch of this sort of education and checklist right at the front end, and think about how we revise the whole thing. And there's a lot that we have to do for that. And so we're not planning on onboarding anybody until fall of 2025. The other thing is our admin for our office had a baby, which is wonderful, but it's left us doing a lot of other jobs. And then developing a plan to sustain simulation education. And I think in our region, we had a model that I think was very physician heavy, like we had to be there to do this. And I think one of the great things that's happened is that we've developed clinical champions in our region who do a phenomenal job giving feedback and creating that culture for education around this that makes thinking about how we do spaced repetition much more sustainable than it was, like 4 EMS docs having to do it all. And beyond having the feedback form for all the RSI performed, just so everybody knows, only like 25% of all RSI requests in our region get intubated in the field. And one of the data that I review is looking for impact on hypoxia. In almost all cases, there's an escalating approach to airway management that makes the patient less hypoxic less hypotensive by the time they arrive at the hospital, and that's deemed a success. But we haven't added sort of the decision-making component into the feedback for performed, but also thinking about how do we translate general like airway management rubrics so that people are getting feedback on all the RSI requests that they respond to, because there's really like a 4-to-1 ratio. And I think it's just as important that you get feedback on your reversal of hypoxia as when you perform the procedure. So that's what we have.
Wonderful. Thank you, Kevin and Maya. I will actually, Marlo, you wanna jump in with your question?
No, that's great and really helpful. I'm curious, for the people who have developed provider dashboards, how do you think through, like, this is an individual responsibility for you as the lead provider versus this is a team sport and we're measuring team performance?
I think it's how that request gets made. So we fielded that idea of how would you react to having a dashboard where you could look up at your individual performance. And it was universally, for the people who showed up, they wanted it. They wanted to know how they performed. And one of the interesting things is Marshall's data show that there's a lot of there is a provider specific issue here actually as well. And one of those things that the provider dashboard shows us is that we have lots of providers who actually have 100% first pass success. Like we have a paramedic in Livingston County who has 100% first pass success for every intubation he's done in the last 3 years. And he's done like 30. right? And we had people who was like, the first pass success was like 40%. And and it let us look at sort of system issues. And then there was other people who thought they were really great. And actually they were just terrible documenters. Like there's a few where like their first pass success is very high. And when we have vitals are good, but they were terrible documenters and they were sort of shocked into saying like, I'm super engaged in this. The people who generally don't want to know their performance are those who through the rest of, there's only a couple who were not like super engaged, who didn't show up like, I can't wait to improve my skills. I'm so glad that we're doing this, which was 95% of the providers in this process. And the other ones, it gave us a lot of insight to maybe who should not be having this credential. And it was extraordinarily rare. But it also makes us think about currently our re-credentialing around this is like an attendance prize, right? Like you perform this many requests and you attend X continuing education. And when you feel the idea of saying this is going to be a performance-based credential, not that like you have a bad airway and you don't meet the metric and you're going to lose your credential, but this is a performance-based credential because the program is patient-centered, not provider-centered. The people who don't want to participate in that weed themselves out. And it's safer for patient care, right? Because people who are nervous about, like, who are more terrified of being measured than of what might happen to a patient if we don't engage in making this better, and looked at our numbers as unacceptable, are the people who end up being like, they don't want to play. That's okay. Because fundamentally, like, patients are harmed by people who don't want to engage in this process.
That's really helpful. Thank you.
So I just, Maya, I so appreciate your masterful approach to improvement science and education and PowerPoint design kind of all together. You always manage to pack more value into a tight time frame than almost anybody I get to listen to. So I'm grateful for that. But one of the things I want to really highlight from what you shared is you have a deeply collaborative approach to doing this. I get to sit in on one of your Zoom sessions with folks in your community, building your change ideas and your driver diagram and your checklist together. And you and I have also been texting a little bit about the difference between buy-in and commitment. Can you just give us a 1 second deal on what the difference is?
It might take me longer. I can do it in a minute, maybe.
All right.
I think, so if you think about the hierarchy of psychology of change, of how do you engage people within a quality improvement project, there's multiple levels of engagement. When you talk about buy-in, really what you're talking about is getting compliance. So I say that these are the things and I'm going to comply and sort of behave. And we have different levels of compliance. It's grudging or not grudging compliance, but in the end, it's compliance. But when you're trying to lead to sustained change in a system, right? Compliance, I always have to be watching. But if I want sustained change in the system, I want people to want to be part of that change. So the levels above that are enrollment, which is I voluntarily participate in this program. And then what we're really going for in quality improvement is commitment, which is I so believe in this mission, in this patient-centered mission, that I'm willing to help redesign the system to help that be. And when I say like, particularly as a medical director, I am not the person out there responding to these. I'd love to be.
Oh, you froze up there. You froze with a great expression on your face. I don't know if anybody else sees this. Is it? She's frozen for everybody. There, you're back.
I don't even know where I cut off. All of a sudden I looked like you leaned in. And I was like, it paused. I don't know where I got cut off.
You're all right. Just jump back in. You were in good shape.
So what was the last thing I said?
Somebody help me with the.
Yeah, we heard you talking about commitment over enrollment.
You're saying as a medical director, you'd love to be out there yourself, but you're not.
Yeah. So because I'm not there, right? I need commitment because I need the people who are doing the work to redesign the system in a way that works for them, which is why I can't be the person to design the checklist or how it's carried or anything like that. The people who are actually out there need to be the people who are doing that. And that's commitment because they're effectively redesigning the way the work is done with the overall goal of safe patient care.
So I thank you for that. And I'm curious for folks on this call, any thoughts that you've got about ways you might be able to increase commitment from the folks who are actually managing airways in your own systems to this particular work. Jason, you just shared something in the chat. Would you unmute, share it?
Oh, I'm just Jarrett Pickett used to say that the difference between commitment and investment was best seen at breakfast. That at breakfast the chicken is invested and the pig is committed, and I think that you're totally right that trying to get commitment from your staff is really important. But to me that made such a great point for me.
Well, and the one of the keys, as Maya's highlighted here, is that you have to be willing to give up a whole lot of control and attachment to the way you think things should be done. If you want people to be engaged in your process and develop their own commitment, no matter how smart I think I am, nobody commits to my ideas. People commit to things that they have a real, tangible, meaningful hand in helping create. It's good stuff. So now is the point in time in our learning session for really just some open dialogue. I'm very curious about how Simple QI is working for you. Is anyone here having problems with Simple QI? Think Simple QI is great? Haven't logged in and have no idea what I'm talking about? You can just unmute yourself and chime in or type into the chat, whatever you like. It is the platform and framework we use to manage these collaboratives. So the folks who program it and develop it have been ridiculously responsive to our requests for improvements and change. So if you've got anything, let's see here. Notice the monthly updates feature is not active for this collaborative. I will ask them about that, Marlo. I appreciate that. Yes, having a single driver diagram for all three projects that's a great point. And there are a couple of possible workarounds for that, but if we could get them to design the option for more than one, and each one would be great. So Kevin, why is it read only for you, not interactive? Were you not listed as a?
So that's a good question. I haven't figured out. Yeah, I think it may have something to do with the fact that I was in the year-long course previously, and maybe like it rolled over and then stopped. But that could be just an individual thing.
Kevin, I'll look at your permissions and get that figured out.
Thank you very much.
But
I appreciate that.
Yeah, Mike, whoever made the suggestion or the mention of the monthly update not being an active feature, where is that located? Because I have not found that.
Let me pull up my Simple QI to.
I just didn't know if whoever made that comment would be able to just give a quick where it's found so I can.
Yeah, I'm not sure where it's shown on the dashboard, but I can show you on Simple QI, something that we use in the year-long quality and safety course. If it's not helpful to the leadership of this collaborative, then we don't have to do it. But it certainly on the quality and safety course, I think it's useful if it's helpful.
Go ahead and share, Marlo, if you've got it up. You've muted yourself. I don't know if you intended to do that.
No, sorry. So here under.
You have to share there.
Sure. Yeah. Sorry.
Not
Zoom native. So here's our team, and then you click on monthly status reports, and then the status report feature is not fully configured yet. So
got it.
If that would be helpful to the leadership of this, that's certainly something we track, and we're working on making progress month to month.
we can talk about adding that. Great.
I have to admit ignorance on that. Is that, what are those monthly status reports?
They're designed to basically track your progress using the IHI 5-level criteria. So it's basically from we understand what quality improvement is, and we're just getting started to we've tested things but haven't seen any improvement yet, all the way up to we've made sustainable improvements, and we're going to publish in the New England Journal of Medicine because we rock. And there's kind of a level in between that kind of lets you know where you're at on that.
So as an example, here's a team from the quality and safety course. If there is PDSA activity and measure activity, you can click on it from there. And then there's also room for a narrative.
Yeah, and the self-assessment there where it says 2, that's the level on the scale from 1 to 5 for progress on your project that it uses the IHI criteria. Great. Anything else from anybody on Simple QI? Any other struggles or challenges? If you haven't got your data uploaded and you need help getting your data uploaded, please upload your data, I guess, is an additional plea from that perspective. Let's see here. What do we have? Any other challenges just overall with the project around measuring Airway 01, which I know that has been a challenge for some folks. Anything else that your team is facing, or any other successes that we had 6 of our colleagues share their projects today, but does anybody else have any successes that other people might benefit from that they'd be willing to share?
So I have I don't know, it's maybe more humorous than anything else, but I have something to show you. We were running into a problem where we were giving ketamine, then giving rock, securing the airway, and forgetting to give post-rocuronium ketamine. So, which is there's something we take very seriously. And if I can find the share button, I'm going to share with you, we did something we call it potty training, which is the humorous part of this. With any luck, you're seeing the potty training now?
We are.
Okay. So you can imagine by the name of this where we put it. So it's in all of the bathrooms. It's in the stalls. It's above the urinals. We put it all over the place. We've done this before with a STEMI measure on time to first 12 lead, time to notification of STEMIs, and then aspirin use. And it turns out this might actually be one of the highest yield things we do. I don't know whether it's the flyer by itself or the location, but it seems to work pretty well.
Love that. Love that. And it lends itself to all kinds of pithy, crappy humor, so I will avoid that.
So to speak, yeah.
Joe, you've got a couple of questions you mentioned in the chat there.
Yeah, so I'll let Chris ask his, but did we ever get any clarification from some of the other measures? So like oxygen documentation, when hypoxia is present, there was a discussion at one time we had about presuming that oxygen is used if, we're given a breathing treatment, or I don't know who would use a BVM without oxygen, but I know that even came up in the discussion that can we presume that oxygen was used, or is for this measure to work, do we have to always have oxygen documented as a separate action?
Jeff?
Yeah, this is one of the challenges we had. We've identified some problems with the measure itself. That is one of the measures or one of the challenges with it. And what we were trying to do, we wanted to use this project to test change and say, well, what is the impact of including that or of, any number of other things. So we wanted to report the data as the measure currently is with the understanding that it's not great and then test some changes. So for example, if one of your changes was to look at that as a discrete source and see if it makes a difference.
Okay.
And then Chris, you had a question as well, is that right?
Yeah, mine was just on Airway 01. So I've only seen this once, but I just want to make sure the data is accurate as it can be. But had a provider treated hypoxia, treated the hypotension, went to intubate, had a video laryngoscope failure, pulled the laryngoscope out, pre-oxygenated, and then first pass success that time. Is that failure per measure?
Yeah, it is. And
Okay.
so this is, I think, one of the key things is failure to achieve the measure does not mean poor practice. And I think this is one of the reasons we want to really avoid setting an expectation of 100%. They did exactly what they were supposed to do. But the definition is the blade passes the teeth or the alveolar ridge where the teeth were supposed to be. That's an attempt.
Okay, thank you.
Yeah.
Any,
And what I do anyway, is when that happens, when we give feedback on all of these, is I say, here's the chart. It failed the measure, but I want to reemphasize you did the right thing for the patient. So this is a really good thing. Don't try to focus your efforts on doing the right thing for the patient, not the measure. They should reflect the same thing.
So I'm old enough that failure of laryngoscopy was having your light come out unscrewed and end up down in the patient's trachea.
Crap, give me the McGills fast.
That has happened to me. It happened to me actually once, and after that, I always checked tightness before I went in. But are failures on video laryngoscopes, as Chris just described, is that common?
So in my experience, the most common failure is the battery doesn't work, which typically, and we honestly, that we are using a UE scope and that friggin' battery lasts forever, so it's not very common. We saw it more with the King Vision, which had the exchangeable batteries. And once we instituted a policy, you change them every month, whether they need it or not, that dropped down.
Anybody else noticing issues with failure of your equipment?
Yeah, at our service, we use the Glide Scope, the first iteration, the Glide Scope Go. And we're kind of at that point where it's considered end of life. And so we've had some battery degradation. And we went through the manufacturer and they gave us kind of a workaround to see if we can revive the batteries, so to speak. But we're kind of at a point now of having to replace some of them outright, just due to battery life.
Got it. Got it. Got it. Anything else anybody wants to chat about before we bring Jason up here?
Actually, I think a very interesting measure based on what I've heard in the conversation is how often are suction batteries failing? And it might be that if we want a higher number, we should say how often are they not failing?
Valid point. And then Marlo, we've got a couple of comments in here from you. You've got one on using an ESO users using a dashboard that you can share. Hired a freelance data analyst to write code to analyze success and failure in process. I'm happy to share that for anybody who needs it. That's great. And then a question about using Microsoft Power Apps to build a feedback mechanism. Has anybody else done that here?
I'm not sure what that is. Can you can you like explain what that?
It's most of us who have Microsoft 365 have this as part of it. And essentially, if your data is in the cloud, it's an app that's built on top of the cloud. So I have kind of a rudimentary version of that in process, and I'm trying to refine it. Want to learn what I can from the people who have done that, and I also may hire some talent to help me with that.
Great. Gabe, I see your hand up.
Yeah, I was just gonna piggyback on that. So we aren't currently using Power Apps for any Airway things, but we recently just employed it for notifying hospital CMOs and other leaders when we have extended ambulance patient offload times. So it's a little finicky, but it does work, and it does allow you to automate certain processes. So we have it in place for notifying CEOs, CMOs, et cetera, when there's an excessive, not for all of our, I hate to say average ambulance patient offload delays, but the ones that are extremely egregious. So
there's a notification sent to CEOs when that happens.
Right. Yep.
Yeah.
So
Okay.
For us.
Thanks.
Got it. Atrium.
So we're using Power Apps for some other stuff within our agency, but for those of you that are interested in getting into it, there's a YouTube channel called Power Apps 911. It's a guy who basically goes over how to use the system. If you have some basic, if you've used Microsoft Access or other database stuff, that's a good way to get into that. If you already have the 365 ecosystem, we're actually talking about building an Airway registry in that system because we're facing the same challenges with ESO of not being able to really track the Airway 01. So I talked with Jeff up in Rome a few weeks ago at a conference up here in Georgia, and think we're going to just build a registry since the number of intubations isn't that many. But it is a very useful tool, and it is low to no code, so you don't have to go learn a programming language. And you can deploy these things on cell phones, laptops, whatever interface either your QA folks, or if you're going to extend it to your crews. And there is the ability with Power Automate to also, like, if you want to do every time you review an Airway, send an email to the provider, hey, this is what we saw, blah, blah, blah. If your agency is using 365, those tools are very easy to learn if you have some basic knowledge of how databases work.
Great. Thank you. Maya?
I'm interested in sort of a general discussion because I can't imagine doing Airway 01 without manual review. And like, because I just do because the monitor review I think is very revealing and important. And I think that's okay. Like, I think in the broader discussion, I think sometimes we worry about like the vendors being able to calculate every single measure, but I can't imagine any system having so many like drug-assisted intubations within a singular EMS system that manual review is prohibitive. Because I mean, we don't have any full-time quality people who do that, and it's actually not that bad, and it's quite educational to actually review every single one of those in detail. And I think some things are high risk enough. The manual review is okay. And just like putting my thoughts out there.
Your thought out there. That's great. Steve?
Yeah, I kind of echo that too. And part of our process improvement is also building that standardization to review those and then doing a face-to-face time with providers, which hasn't really happened before. And I think that's really going to move the needle, so to speak, for us with our engagement with our providers and kind of driving that improvement from the ground up, because they then know that they have also a team helping them kind of look at that background data and kind of bringing that forward. But my kind of question for the whole group is, those of you that are looking at the pit crew approach to Airway, if you have a smaller system and maybe it runs the gamut from having 2 people on scene to 3 to 5, like how is that expanding and shrinking kind of personnel play into your approach to that pit crew?
I know how we did it for cardiac arrest, and that we had specific maps for if you're 1, 2, 3, 4 up to 5 folks on team. But be interesting to hear what other folks have got. Steve, you've got your hand up, Steve Cohen.
Thanks, Mike. I agree. Manual review for the RSI cases gets done, but as far as the registry and everything, we pull all the data automatically, and it's the cases that fall out that get a very close manual review to see if there's something in there that essentially, as a couple of people have mentioned already, passes, i.e. looking at the monitor file to see that the SPO2 or whatever was there where it wasn't documented. And I find that really cuts down on the work, not only with this stuff, but with a lot of the QA stuff overall.
So Steve, are you saying you let the computer do like I don't know, maybe a first pass through this for you?
Yeah, and we use First Pass for that too. We're still trying to refine some of the filters in First Pass for the Airway 01 stuff and all that, but that's exactly it.
Sounds like somebody named the product well.
Tom, I saw your hand go up and down. Are you?
Yeah, I was just gonna, I don't know. Yeah. I was just gonna kind of piggyback on what Maya said, and the whole conversation about buy-in that we had earlier, and I think that again another way to get is another person that works in somewhere that's doesn't have a whole team of people to review charts. This is a way to help people see the value in this metric, is to get them to kind of look through these charts a little bit and talking about them as a group. And I think that's another way that if you can use your provider, your clinicians to do some of this, that's another way that you generate more discussion and improvement ideas is, hey, because we do this at our QI meeting, like in full disclosure, Nick looks at all these and fills our data tracking out, but we pull all of these up because there's so few at our CQI meeting each month, and we watch all the CMAC videos, and that's where things come up like, oh wait, like this one little thing went wrong, and then somebody else is like, oh yeah, that happened to me 2 months ago, and yeah, that happened to me too, and we would have never known about it, had we not reviewed that specific case. And now we have a problem that we found and a solution that gets generated from discussion with the clinicians, all because we were reviewing these high risk events.
Sounds good. Sounds good. Any other thoughts or contributions here? Let's go ahead, Jason. Let's invite you to the stage to talk about has it really changed, not just data collection?
Thanks. So my nemesis.
Yes, it's there.
All right. So, well, I love Star Wars and I love Legos. And if you don't, then I'm sorry, you have to sit through this. It won't be very long, I promise you. But, doing things, changing things that are complicated generally involve some bit of a mess. This is what I wanted to build. My son really wanted this. The thing cost more money than anything should cost for a toy, at least. He should be at least 20 to be able to get a toy that costs this much. Anyway, I decided to embark. And being a data person, I decided that we needed some measures for it. There are 7,500 pieces in this monster. 7,500 pieces. There are more than 1,300 steps involved in creating this. I needed a measure so that I could know that if I was going to make a change, if I was going to make progress, I could see it. I could see it because this thing has 7,500 pieces and you can't see it when you start putting it together because you don't know what you're building. It looks like a little toy, not some massive thing. It wasn't good. The good news is that I also have an instruction manual, and this is really cool. The instruction manual is 500 pages. That's not so cool. This instruction manual reminded me a lot of this whole project because we have a very complex project here. It has an instruction manual, which is not 500 pages, thank God, but it does exist for you. And in doing that, I thought, okay, well, I'm working improvement. I build things. I can get my Lego going. So I open the box, and this is what I find. Wonderful. Nothing says, when I first saw this, my first moment was, okay, this is going to be great. 7,500 pieces. Okay, I wanted to close the box, see if I could find the receipt and return the thing, because nobody wants to build this now because this is way, way, way too scary. What have I gotten into? I wanted this thing. This does not look like this. This is a problem. What am I going to do? So 7,500 pieces. Did I say that? So I decided the first thing I would do is go back and start building and monitor my success. So I decided I would chart it. So as I started working through, I had done 137 steps in the process. That's 9.8%. So obviously I'm making good progress in my build. So I'm making progress. This is all I need to make progress, right? Because making progress is charting things. I know that because I like data, and charting things is really, really the best way to make progress. But yeah, I still have this. I still have like a lot of pieces, and I'm not really making a whole lot of progress, and I'm really not sure how I'm going to get back. So I started looking at the manual. It's like, okay, I can make my way through this manual, and I'm going to finally get something done here. I start realizing that if I just start putting pieces together, if I can get through one of these little packs and follow the guidebook, and I can get pieces put together, I can start building it. So I can't see my device here. I can't see it. It still looks like a bunch of pieces of bricks. Nothing's really looks like a Millennium Falcon yet, and that's very disappointing for the whole family. But I'm making progress. It's incremental. It's small, but I'm making it. And I'm doing that by opening one pack at a time and following the step one step at a time. So Airway seems like a beast. It seems overwhelming at times because there's so much to do. Don't get stuck on the data. Don't just do data. Don't just do measurements. Measurements important. But if you just measure things, nothing gets built. You got to put the pieces together at some point. Even though it's scary and even though it's overwhelming, just start putting a couple pieces together and you'll start making progress. Patton said, you know, a good plan violently executed now is better than a perfect plan next week. And I think that's really true. Short testing timelines, 2 weeks, not 6 months. What am I going to do today, this week? Not what are we going to plan? How are we going to get this planned for next week? Maybe we can work this into the cycle in the next budget year. It's got to happen quickly, and it's got to be like 2-week cycles, really short. Just involve a couple units. Don't involve the whole world. You're not trying to change the world all at once. Test things frequently. But don't get caught up by looking at this giant project and thinking, oh, I can't do it. Because you can, one piece at a time. And we do have a guidebook. We made one when we first started. Other places have been successful in changes, and we've put down a list of the things that they did. So if you don't know where to start, pick a list. Use something that somebody said today, you know, use a checklist. Steal Maya's checklist. It's awesome. I loved it. Or find your own, test it in your system, because what works in one system may not work in another system. But see, I told you I would do this really quick because it doesn't take as long as all that. Building the thing takes a little bit of time. So I'm not through with that yet. I don't know if I'll ever be through with it. Maybe it's like continuous improvement where it's just getting bigger and bigger. But anyway, so that's all I really wanted to say was this whole purpose of this learning session is really to get people moving, to get people doing things, to make changes. They don't have to be, you know, you don't have to be right. You probably won't be right the first time. You probably won't be right the second time. But as you work through it, you'll be more right than you were. And every time you try something, you'll learn something. And you'll figure out, hey, if that didn't work, you'll figure out why. And then the next time it might work, or it'll work better. And the key is just movement. So don't be caught up in trying to get the perfect fix. Don't be caught up in trying to make something that is going to solve all your problems, because it's not. But make a change. So today, this week, make a change. Make it while you're on a call with 80 people who all are interested in the same thing, because everybody wants to make a change. Make it now, because next week, you know, you're going to have something bad happen. You know, a truck's going to get in a wreck and you're going to be involved in that, or something else is going to distract you, or you're going to have your attention somewhere else. Make a change now, and schedule it. Schedule the first meeting and schedule the second, the third, the fourth. Schedule like a month of meetings for it, like one every week, so that you have a deadline that is set up in your meetings, so that you know next week we're going to talk about this, and then in 2 weeks everyone knows, oh, I gotta have an answer in 2 weeks. We're going to have to chat about this then, so that everyone can have an understanding, and it keeps you on track. And then do the one thing that is really hard to do, which is like the worst thing. I used to say I would work for free in EMS if I didn't have to write any charts, because I love taking care of patients, but I hate writing documents. It's horrible. But the really important thing here is that, same thing with documentation. If you don't write it down, it doesn't get conveyed to the next guy. And if you don't have a good document, then when you drop them off at the hospital, they don't know what you did. And if you don't, and then they're going to have to repeat everything. And if you do a whole lot of work here and you've done amazing, amazing work, put it into Simple QI, fill out a PDSA, do it all. And that way everyone else can look at it and think, okay, I don't have to do that now because Jeff did it. I don't have to do that now because Chris did it and they do a lot of stuff in such way, or you can steal things. It's great. So that's all. I didn't mean to schedule like a huge thing, Mike, so I hope it didn't mess up your time frame here, but I just wanted to tell everybody, do something, make it happen. That's it.
Call to action is the message we want to leave folks with. And I guess Jeff, any other thoughts here before we ask people to put in the chat what specific action they're willing to do here in the next few weeks, whether it's upload data or test ideas, or hopefully both?
No, I think Jason's point here about just move is incredible. So you said it way better than I could.
And I'm not going to belabor it anymore. I would love to, if you're up for it, to just go ahead and put in the chat, what it is you're going to try, and and that if you haven't got your data uploaded yet, if you'd put in there, I'm committed to getting data uploaded. I'd love to see that. Because ultimately the benefit of this for all the patients folks in this circle care for, and hopefully all the other patients in the country who need airway support, who are going to benefit from our summative work here and recommendations, would be good to bring this project home with a robust set of changes and producing real meaningful results, similar to what we've seen with our folks sharing today. And so I definitely, as we wrap up here, I really want to thank all of the systems that presented and shared your wisdom and experience here. This is how we grow as a profession and how we make measurable, meaningful improvements. Let's see, you're going to update our January and February data. Thank you, Jeff. Checklist individual review with all paramedics. Julie, that sounds great. And then the checklist and data backlog. Thank you for Atrium. We appreciate that. Checklist and kit dump. That sounds good. Last issues with baseline data, and we'll upload this week. That's great to hear, Marlo. And SPP prior to intubation. This is good. Data is current. Continue reviewing CQI goals, and PDSA will be on implementing a new aggressive airway mindset training program. Wonderful. Please share your results as you do it. 3 test areas identified, Tim. That's great. Yes, Tom, measuring the impact of last month's training, and there's a fabulous framework. I'm not sure if you're familiar with the Kirkpatrick post education framework. That for those of you who haven't done it, if you're doing educational interventions, it's a 4-level post education assessment of your effectiveness of your education program. The first level is the feel good sheets that are did you like the hair color and mustache combing of your presenter, kinds of things that we get at the end of all education sessions. The next level is a retention assessment that looks at can people regurgitate what they learned, usually with a quiz or a test. The third level is, did it actually change practice, and did your practice actually change based on the results of your education? And the fourth level is patient outcome, is do patients have meaningful, measurable improvement in the outcome of their care based on your educational intervention. And too often in EMS, we see QI married with education, and people say, "Oh, I did a training class," and that's where it ends. There's no follow-up or assessment around that, so that's an important one. And Dave, developing a way to streamline your data collection. Gabe, update your data and do PDSAs. And Gabe, I would also encourage you to add figuring out a way to get commitment and enroll the folks in your system about what it is you're doing here. Kind of being inspired by Maya and Kevin's approach to things. I think it might be worth thinking about there. Work on your PDSAs, develop a feedback system to paramedics, and get caught up on Airway 05. Good. Working with providers about -1A standard reviews and exploring the idea of a pit crew approach. If any of you have got an airway management pit crew, I know a lot of places have it for cardiac arrest, but if you've got a pit crew framework that you use for airway management, please share it with us. Let's get it up into the resource area. I haven't seen a lot of them, and I would bet some benchmarking and swiping ideas from each other would be useful from that perspective. Marlo just asked about the Kirkpatrick thing. I will pop one into the chat. Jason, Jeff, any last words of wisdom for anybody here?
I'm going to surprise everybody and say I have nothing to say.
Wow. I'm gonna mark this in my calendar. It doesn't happen. And Jason, anything else?
No, I look forward to seeing all of your wonderful cycles because you guys are going to do great.
Perfect. And Cherie, anything else before we wrap up?
I'm gonna go with the Jeff approach here.
All right.
And say, I think we're good, except obviously you know how to reach me if you need anything. We will do anything. Can't figure out how to get the data, the PDSA. Hey, there's this feature in Simple QI that I think we should use. And I don't know of it. We'll make it happen. So, anything that you need, getting your data together. Sorry, now I just got distracted and I'm laughing at Jeff's, sorry, I should turn my video on. Laughing at Jeff's message. So I apologize. Thanks for the distraction, sir. Anything at all, just let us know. We're here. Nothing is too big or too small.
Absolutely. Absolutely. And with that, I think we'll call this to a close and give you 25 minutes back to your day. Don't say you didn't get anything out of this. It's good. Thank you all.
And I'm sticking around for a few minutes if anybody has any burning questions that they'd like to just get answered right now.
Take care, everybody. Bye-bye, y'all.
Thank you, Jeff. Great.
I would just say I'm embarrassed to admit I did not realize that the threshold for Airway 05 was different than the threshold for oxygenation for Airway 01. I'm just curious how are people handling that? Are just keeping two different data sets or just keeping one value for Airway 01 pre-oxygenation and another value for Airway 05?
Got it. I just realized I was processing the threshold that you are looking for. Yeah, 94 versus 90. Is that what you're talking about? The SpO2 value. Yeah, I'm not 100% sure, it depends on how people are, whether they're manually, reviewing it or doing it from an automated thing. But I mean, it's the same set of patients. It's just, separate tracking of the SpO2 value.
Got it. Okay. So it's the same.
Yeah, we're looking at
It's the same denominator, but
yeah, it's the
different
same
criteria
group
for the
of
numerator.
patients. Yeah, those that you're going to intubate who aren't in cardiac arrest. And then the
Okay.
one is, you know, prior to intubating, were you above 94? The other one is peri-intubation period, did you drop below 90?
Got it. And just so I can help
Yeah.
to explain that to my staff is, can you give me any background on the kind of the logic behind that, or anything info
I'll
that?
let somebody else who's clinical explain it, but it's about the initial is the pre-oxygenation so that you're preloaded with before you go and do the intubation, because then you're likely going to drop. So it's about
Right.
getting that pre-oxygenation level up high enough. 94% is what the, you know, the evidence shows. I mean, so up to, you know, up to the protocol, provider discretion, you know, if you allow, I know some people like Jeff would probably be like, nope, you're not at it, you know, don't do it. But I do know I've, you know, seen other cases where there's
Yeah,
like no
so
other option, and that's what they do. So
it's a starting point. So the idea was you do your nitrogen wash and you get your sats up to 94 before you attempt, and then the sats are likely to drop during your attempt. So if they drop below 90, so that's your
Got
miss
it.
for the other one. So it's supposed to allow you to have a mark that you hit before you start, and then allow for the drop during the procedure.
Got
But
it.
if they're well oxygenated and they're actually, you know, and you wash out the nitrogen well, it takes such a long time for it to drop those
Yeah.
usually. So it's more than enough.
No, it makes sense. No, and I take responsibility for that. I hadn't
Totally.
I hadn't realized that those two thresholds were different, and so I'll make sure that's reflected in our data.
but I mean, we also just kind of threw that in there as well, because
yeah,
as we were
Is that
looking at the measure, we're like, you know, you're not necessarily going to be, first of all, most people, you know, whether they realized it or not, the percentage of agencies who had indicated they were already tracking that in some way was pretty high. So we were like, well, why don't we just get it? Because you're not going to have success in Airway 01 if you're not doing that pre-oxygenation part. So it was sort of
got it.
we were focusing on the outcome, which is Airway 01, but a process measure to get there is the Airway 05.
Yeah.
So, I mean, we can't necessarily like require it because you didn't really sign on to do it, but we're like hoping that people will do it just because it is helpful in the process.
No, and I think it makes sense to track. I'm just thinking like for the fishbone diagram, like you could technically have a case that didn't meet Airway 05 on
Yeah.
the pre-oxygenation, but passed on
Yeah.
Airway 01
Yep,
based
absolutely.
on, they say a SAT of 92% prior to intubation. Okay,
Right.
no,
Yeah.
that helps. No, that's all I have. I will get that reflected and uploaded. I'm gonna sign up. Thank you guys.
All right, see ya. I think we're complete here.